Good morning to all the dignitaries and delegates. St. Peter's Institute of Pharmaceutical Sciences is delighted to welcome you all for this webinar on role of clinical pharmacist in the management of autoimmune diseases. I would now request our principal sir, Dr. P. Rajshekhar Reddy to deliver welcome address.
Sir,
Sir,
please
please unmute yourself, sir.
Unmute, yeah.
Good morning, everyone. On behalf of St. Peter's Institute of Pharmaceutical Sciences, I'm welcoming you all. I'm more than happy to welcome all the speakers who are happen to be our alumni, and very much looking forward for their sessions to be wonderfully going. And also, I wish them all the very success. And also, I thank my management for giving this opportunity and making this continuous webinars as a series. And also, I welcome Manasavina, Shaili, and Charmati madam. And now I'm pushing it back to the organizer. Thank you.
Thank you, sir. I would now kindly request the visionary behind St. Peter's Institute of Pharmaceutical Sciences, our chairman, Sri Jayapal Reddy sir, to enlighten us with his presidential address.
Very good morning to you all. It's a wonderful day to start with the role of clinical pharmacist in the management of autoimmune diseases. I'm so delighted to see all the three wonderful speakers, Manasa, Veena, Shaili, and Dr. Sarumati. All the three speakers, I think they're going to touch on the three areas specific to the role of clinical pharmacists. Because this is an area where we have to showcase our importance and our value addition to the healthcare system. That's where the missing link is really going what you call less in some of the fewer countries. I'm so happy nowadays in India. I think day by day the recognition and acceptance of a pharmacist role in management of these kind of diseases, I think it is enormous. Even doctors are welcoming the knowledge on every kind of diseases where you are able to give the best drug dosage designs for every given patient, so that there is no side effect. There is no what to call patient undergoing stress or anything. You're really bringing a lot of hope to the entire medical healthcare system. So earlier the role of clinical pharmacists was very limited, but today out of I think we have close to 300 PharmD colleges, means there are 300 bedded hospitals, and close to 10 batches of students have gone out. So there's a enormous kind of clinical pharmacist availability growing day by day, and we have witnessed the importance of the clinical pharmacist in intervening in the entire prescription or patient care, monitoring the patient care, advising patient care. I think hope in another 3 to 4 years, you are so well recognized in this country, and the patients will also be waiting for you to take your services, because they know your role is so important for them. And I'm so happy to appreciate the faculty, principal, and the Department of Pharmacy Practice, and all the department, pharmacology, Sutics, and cognicy, and all the department, chemistry, for bringing the last couple of months. I think you're able to bring in the approvals for already we had Animal Ethical Committee approvals, Human Ethical Committee approvals recently approved by Drug Control General of India from CDSO, and Pharmacopoeia Commission. I think just a couple of days back we received approval for ADR Monitoring Center. I think very few colleges in this country has got these kind of facilities. I think the students at St. Peter's and even the other students, I think you can take the benefit out of this, uh, because you are the right people to really find out areas and report so that best medical attention can be given to the patient care. Our ultimate aim is to really make patients safer, healthier, and getting away from unnecessary adverse drug reactions. So I think you are the right people, because enormous kind of drugs that are being manufactured across the globe. I think you are the right people to really identify the exact dosage regimen for the any patient with the help of the doctor. So with a few words, I think today's session will be giving a lot of insight, a lot of learning, and all the three speakers have got different kind of area of experiences talking to the patients in their life and also educating the patients out in the hospitals. So I wish you all the best and happy learning. And I really appreciate all the three speakers for accepting for today's webinar. And this will be an insight learning for all of us, including delegates, students who are listening to this particular webinar. And I wish you all the best, and I appreciate today's convener, Shivani, Dr. Rajsekhar Principal, who is in charge for the entire program. And I also appreciate Dr. Praveen, Dharani, and Ranadir for making this particular program going on this today's event. So once again, congratulations and appreciation to all of you. Thank you.
Thank you, sir. Thank you for your thought-provoking words. Now I would request Dr. Praveen, HOD, Pharmacy Practice, to enlighten us with his uh, webinar. Enlighten us with the webinar.
Good morning, everyone. It feels wonderful to meet you all once again for yet another session from St. Peter's Institute of Pharmaceutical Sciences. Today's session is about management of autoimmune diseases, especially from a clinical pharmacist perspective. We are delighted with the overwhelming response from our delegates. We have close to 70 pharmacy institutions and few NABH accredited hospitals, delegates from such institutions for our webinar today. And we sincerely hope the speakers of today's session will cater to your needs on autoimmune diseases. Without much further ado, I would like to request the convener, Ms. Shivani Raula, to start the scientific session by introducing the first speaker, Ms. Manasvi.
Thank you, Dr. Praveen. Let me introduce our first speaker, Mrs. Manasavina Valapadasu. I'm glad to introduce Mrs. Manasavina, who is our first resource person of today's session. Also, I'm happy to share with you that Manasavina is an alumni of St. Peter's Institute of Pharmaceutical Sciences, as she completed her pharmacy practice in the year 2015. Mrs. Manasavina, working as a as a pharmacist at Doffy Pharmacy, Bios T. Rose Shopping Complex, Victoria, Mahi, Seychelles, since 2016. She has more than 5 years of experience as a pharmacist. She is a competent professional with hands-on experience in various pharmacist activities like indication and use of drugs, dosage forms, adverse drug reaction monitoring, contraindication, patient counseling, abuse of controlled drugs, dispensing and accountability, and ensuring proper documentation. Mrs. Manswina has 3 years of experience as assistant professor, Department of Pharmacy Practice at St. Peter's Institute of Pharmaceutical Sciences from Jan 2013 to 2016. She attended national and international seminars and presented papers. It's my pleasure to introduce you, ma'am. Please proceed with the session.
Good morning, everyone. So, Honorable Chairman J.P. Sir Garu, and also the Honorable Principal Dr. P. Rajshekhar Garu, and the Dr. D. Praveen Sir, and also our coordinator today, Shivani. So, thank you so much, sir, for giving you this opportunity to me. And I would like to explain all about the autoimmune disorders throughout the world, what's happening regarding these diseases, and what's the role of clinical pharmacist overall the world. So thank you so much once again, and I wish you everything will be fine, sir. Thank you so much for this session once again. So I'll share my slides now. I'm going to start my session. Thank you. Good morning, all. I, D. Sabina, I'm the pharmacist at Dauphin Pharmacy in Seychelles. Today, we are going to learn about an overview of autoimmune disorders and the impact of pharmacist care. The contents included immunity introduction, autoimmunity, and the types of autoimmune diseases, diagnosis of individual diseases, and the treatment options, pharmacist care. These are my references. Before, we have to know about the immunity condition because this is an initial part of the autoimmune disorders. Immunity, it's a state of protection from the infectious diseases. So, normally, immunity is a process how this system protects our body from the antigens which are coming from the environmental factors. Normally, immunity is categorized into two different conditions, innate immunity and also the adaptive immunity. Innate immunity in itself indicating that it is an initial immunity. That means the rapid immunity. And the second one is adaptive immunity. It's nothing but it's a slow process, but whereas it lasts for long-term condition. That's what adaptive immunity is categorized into two different sections, natural immunity and artificial immunity. The name itself indicating that naturally our body will protect from the antigen entry into our body. So naturally, our body will produce the antibodies to stop the antigen enters into the body. So normally it is again categorized into active natural and the passive natural. Naturally active means our body produces the antibody without any other introducing into the body. Whereas the passive, we take the antibodies from our mother or through the breastfeeding category. So that is a categorization. Active means inside the body, whereas the passive means from the mother. That is naturally. The artificial, again active and the passive. Artificially active means vaccines. Now throughout the world, COVID is a very, very problematic condition. So we are taking all the vaccines. This comes under artificial active. So to produce the immunization and the antibodies in the body, we take actively from the outside. We are taking the vaccine that comes under active. Whereas the passive, we all know that nowadays everyone is saying blood donation. Likewise, who develop the antibodies with the COVID, they are donating the antibodies as well. This comes under passive artificial. So this is a little bit introduction about the immunity. It's nothing but protecting our body with the immune system is called immunity. That's a simple overview. And coming to the next thing, what is a system? This immunity can be done by the immune system. So immune system should have something special component to run the show. So that is white blood cells. These are the constant patrol. That means protective guards for the body. So main important guards for the body. So what happens when the antigen or any toxic material exposed to the body or enters into the body, immediately the WBC will catch and responses to the brain so that it will multiply. All the body will respond towards it. Something came into the body. We have to fight against it. So that is called antibodies will be produced from the white blood cells. That's what we call guards for the body. Initially responded by the WBC. So where these are located? Normally, these are located in the 5 different parts of the body. Thymus, which is located at the neck region, and whereas the spleen beneath to the abdomen, and the bone marrow, which is located at the between the bones, and the lymph nodes, which are linked throughout the lymphatic system in the body. Again, WBC is not a simple thing, which is categorized into different branch. I'll give you a simple code for you to remember easily. because WBC are very, very essential cells of our body. That is called never let monkey eat banana. It's like a simple quote to remember for all the students when I was an assistant professor, but I'm just giving a simple quote. This is never let monkey eat banana. The neutrophils, lymphocytes, monocytes, eosinophils, and the basophils. So, out of these 5 components of the WBC, the last 2 are not that much essential. They do their job, but still, it's not that effective like others do. So definitely, out of these 2, again, lymphocytes are main important cells for the WBC. Again, the lymphocytes are categorized into 2 different types, B cells and T cells. The name itself indicating that B, which is derived from the bone marrow, and the T, derived from the thymus, which is located at the neck. Very important ones. How they work, how they protect our body. B cells, which is released from the bone marrow, and very, very important, which can produce the very important protein material, which is a chemical component. It's called immunoglobulins. So these are common with this situation happening. When antibodies produces, the immune responses starts. That means immunity starts. What are these immunoglobulins? Immunoglobulins, again, categorized into 5 different types. Immunoglobulin G, immunoglobulin M, A, E, and T. In these 5 groups, you can have a look. The first alphabet is A. We know that. A is the first one. As well, the 5 immunoglobulins, A is the first one. So immunoglobulin A is a main antibody which covers our body. We know that what are the main entry points of antigen enters into the body is, the first thing is eye. That is lacrimal fluid. Where the second one is, we all know that, we all wear the mask every day to protect our immune system. That is our saliva and also the mouth region. The oral cavity and the lacrimal glands are the main entry points to enter the antigen into the body. To stop these things, the immunoglobulin A produces at the eyes and oral cavity. So remember, A is an important thing, which is a main covering point for the human beings. These about B lymphocytes, which produces the immunoglobulins and start the response. So B is an initial thing. So what happens? B cells targets the antigen. So what's the role of T cells then? It will destroy the antigen binding. That's the main role. So they respond each other, whereas to destroy the antigen entry into the body. So B cell targets, T cell destroy. Finally, the body will be normalized. That's the main importance of the WBC role. And that coming to the next point, immune system strongest with the age. Definitely, when the age grows, our immune system will be stronger. That's what we all see, that children can get more sick compared to the adults. We are stronger than the children and all the toddlers. We all know that in our lifetime, well, definitely a little bit of infectious condition will be once in a lifetime. That is called chicken pox. So what happens? Our body can have a copy of all the antigen, which is already having the earlier stage. Once the infection we expose to that particular condition, our B cells and the T cells and the WBC, all our immune system will memorize what happens in our body before itself. So that in the future, when it comes to our body, it will recognize, okay, this was already finished before itself, so no need to further. The already antibodies will be developed in our body. That's what we know, that chickenpox only once in a lifetime. So that the copy will be remain in the body. So this is about little introduction of the WBC and what's the role and important role of the immune system. Now let's get into the other one. This is autoimmunity. Immunity, we already discussed, it protects the body. But what is immunity? Autoimmunity is the immune system, that means the protecting system, which targets the healthy cells rather than the foreign pathogens of faulty cells. That means in this situation, what happens? Our immune system cannot distinguish which is self, which is non-self. That means the immune system not able to find what is antigen and what is our own self. Why it happens? What could be the reason? That we'll discuss slowly. But this is a main example and the main definition of the autoimmunity condition, which cannot distinguish. So in that condition, what happens? Our immune system destroys our own cells also. So that is a main problem happening with this autoimmunity. In general, depends on the severity of the autoimmunity. It is categorized into two different levels: low level autoimmunity, high level autoimmunity. The name itself indicating that again, low level means a bit less mild condition to moderate condition. It's not that severe. It can be curable with a slow therapy. But whereas high level, it's very difficult condition. We have to go on the chronic therapy and also the long-term treatment. So that is a big trouble for the human beings to damage our own system and their own cells. Coming to the third point, types of the autoimmune diseases. This autoimmunity causes what? Autoimmune diseases. Autoimmunity leads to the diseases. Here, I would like to point an important note, the difference between the diseases and the disorders. Maybe you can find out. Initially, I've done a slide overview of autoimmune disorders, but whereas here I did some diseases. Now I would like to give some little introduction about these 4 points. Before that, diseases and the disorders and the syndrome symptom. Initially, according to the health status, they have classified into 4 different sections: symptoms, syndrome, diseases, and the disorders. We all know that symptoms are nothing but physical appearance of the body, fever, and also the pain, the swollen condition, inflammation. These are the common symptomatic conditions that you can see visually and the physical appearance of the body. Then what is syndrome? Group of symptom is nothing but syndrome. Altogether mixed is syndrome. Then what is disease and the disorder? Disease, it's nothing but it's a bit measurable condition of the health. We can measure the condition. Whereas the disorders, we cannot measure. It may spread to the overall the body, from here, there, neck region, joint parts, muscle, everywhere. If one specific organ is damaged, condition is nothing but a bit of disease, whereas the disorder, it cannot cure. It takes long term to cure the condition. I'll give you a simple example. Disease, COPD, chronic obstructive pulmonary disease. We know that this is a bit of disease because the symptomatic conditions, we can measure it. We can cough, we can sneeze, and also we can have some shortness of breath. We have some particular symptoms for the particular organ. Whereas the disorder, we can't even measure the condition. We know that rheumatoid arthritis, psoriatic condition, which is spread to overall the body. So that's what autoimmune diseases may lead to the disorder condition. That's what I put this slide for the types of immune diseases. When you know the types of autoimmune diseases, which may lead to the disorder condition, which is very severe scenario compared to the diseases, because diseases can be cured with the therapy, whereas the disease is a bit difficult for us to treat in a way. Now we'll discuss about the autoimmune diseases classification. In a basic way, it depends on the targeted condition, categorized into 2 different sections: organ specific and non-organ specific. Again, the name itself indicating that organ specific is only one of the organ will be damaged, not going to spread overall the body. Whereas in non-organ specific, it can spread one by one, and the complications will be seen in that particular condition. For example, if skin-related problem comes, means it will reach to the kidney, joints, muscular, blood vessels, brain, everywhere. That's what we say that. Mentally retarded people, it's called disorder. Any condition we call asthma or COPD or any kind of simple diseases we call disease. Disorder is nothing but genetically we can get it into the body. Whereas diseases, exposure to the condition, like environmental condition or any toxins exposure. That's about disease and disorder, a little bit difference between them. Next, how these diseases or the disorders can be exposed. What are the main triggering factors which can cause these autoimmune disorders? So we know that why our immune system is finding self to destroy. Why our system is making like that. The main important is gender. All we know that female take more stress than males. It's a all common information. Female takes a lot of things, they do a lot of work, they do everything, most of the stress conditions. According to the incidence rate and the epidemiology conditions, it is saying that female get more prone to the autoimmune disorders comparatively males. Age group, definitely, as we discussed in the earlier, age increases, the immunity level will be increases. So that's what middle age group and the young age group are more prone to the autoimmune disorders. Genetical conditions. Our family history is main important. We may get it from the chromosomal things and the genes which are carrying from our father, mother, everything. And the obesity, weight is very important. When the fat is accumulated in the body or any adipose tissue, which can cause the main problem to the body, the immune system cannot distinguish which one is fat, which one is cell. We don't even know. So weight loss is very important for this. Smoking cessation and this toxic materials. We have to stop the smoking. So because tobacco, which contains the smoking thing, we have to make sure how it is entering into the body, directly reach to the lungs so that immune system can target the tobacco. Instead of the tobacco, lung cells also exposed to the damaged condition by our own immune system. And certain medications. This we'll discuss about the impact of the role of the pharmacist care, but just I'll give you some examples such as isoniazid. All you know that anti-tuberculosis drugs and vaccine, quinidine. These are the common medications. When you take this medication, if your body can't tolerate the medication, it may lead to the other way, that is called drug-induced autoimmune disorders, if your body cannot tolerate that particular medication. And finally, infections. Infections, nothing but any bacterial or viral infections can cause the autoimmune disorders. Now, we'll see the different classifications or the different types of autoimmune diseases. 80 different types of diseases are existing overall the world, but we cannot read each and everything. What are the main and high incidence rate of the autoimmune diseases going around the world? The main, I have chosen the 14 important common diseases that we'll discuss an overview that I'll explain one by one. The first important one, diabetic 1, that means type 1. We know that diabetic normally categorized into two different ways, diabetic mellitus and the diabetic insipidus. But the diabetic mellitus is a common autoimmune disorder. I'm not going to take much about it because our second speaker is going to explain much about it, I hope. So this is diabetic type 1 comes under the autoimmune disorder. What happens? Our immune system particularly targets the pancreas, which located under the beneath the abdominal part. So this pancreas releases the important component is called insulin. This insulin regulates the glucose levels in our body. Once our immune system targets this pancreatic, what happens? It won't even releases the insulin. Thereby, the glucose levels will be increases. Which condition we can get this? Again, spread to the different risk factors. That's the main thing. But diabetic condition is a disorder. Why? Because it's spreading to overall the conditions. Heart, kidney, eye. That's what we know that. Diabetic nephropathy, diabetic neuropathy, a lot of problems will be there because of the spreading overall the body. Just about little introduction of type 1 diabetic mellitus condition. So main treatment for this is, we all know that anti-diabetic conditions like such as sulfonylureas, bipirines like metformins, glipizide and all, we can treat like a initial treatment. And the main important is second one, rheumatoid arthritis. Immune system attacks the joints and also the bones. We know that B cells released from between the bone marrow. B is bone cells. So the joints and bones will be affected by our own immune system. Our immune system will go and attacks the cells of the joints. So it will multiply. It will multiply and something is happening in our body. The body will respond. The body will start showing the symptoms. So the main symptoms of the rheumatoid arthritis, pain, very common symptom of the arthritis, and also the inflammation, swollen condition, and redness of the particular area where you get the pain. That's about rheumatoid arthritis. And the common treatment options, we know that painkillers will be given, that we'll discuss one by one. And the third important classification of autoimmune disorders, psoriasis and also the psoriatic arthritis. Again, it's a disorder because it's spreading to the joints as well. Arthritis, itis is inflammation. What happens? The immune system will reach to the skin and it will multiply the skin cells quickly. Once the skin cell, that's what you can see the different kind of blisters and the rashes on the skin with the psoriatic patients. That is the skin cells multiplication by our own immune system again. And the fourth one is multiple sclerosis. Just see the name, multiple sclerosis, M and the S. First two parts, main alphabets, MS, that is called myelin sheath, which is related to the myelin sheath, multiple sclerosis. So what happens? The immune system will attack on the nerve cells, which can connect from the myelin sheath from the brain to the nervous system, like a spondylosis condition, which can cause the inflammation to the spine and everything. it damages the myelin sheath impulse, which pulses will be reached from the brain to the body. These pulses will be blocked. So by the time the body cannot respond properly, it can cause some pain, inflammation inside the body. So immune system attacks the myelin sheath condition, causes multiple sclerosis. Central nervous system will be a bit abnormal. Okay, abnormal functioning of the own system. And the fifth important one is systemic lupus erythematosus. Lupus, we all know that butterfly color patches will be there, like a butterfly model. The patch on the skin will be, it looks like butterfly color, shape like patches. So that's what it related to the skin again. The skin cells will be multiply, which can form the autoimmune disorder on the skin, related to the skin. Again, it's a disorder which may lead to the very bad condition, reach to the joints, bones, kidneys, brain, and also the heart as well. It can cause some cardiovascular diseases. So this is very dangerous than the third one, like a psoriatic condition. Psoriatic, we can treat with some little bit of long-term therapy and with the common medications. Systemic is a bit dangerous than the psoriatic. Both are equivalent conditions, but the main difference is butterfly color patches and the shape model. And the sixth one, inflammatory bowel diseases, bowel, related to the abdomen. Again, inflammatory bowel diseases categorized into two different sections. Crohn's disease, ulcerative colitis. That means immune system will go and attack the gastrointestinal tract. The intestinal flora will be damaged. Crohn's disease is a mouth to the anus part, whereas the ulcerative colitis is a large intestinal part, inflammation to that particular area. So the abnormal functioning of the intestinal flora causes the digestive problems, abdominal pain, any diarrheal condition, constipation. It depends on the condition. Constipation, either diarrhea. So make sure the immune system, if it affects on the bowel, is a very big trouble as well. And the other one, Addison's disease. Addison's disease, AD, so which is effect on the adrenal glands. Where it's located? It's on the top of the kidney condition, like, which is the location of the adrenal glands I'm explaining. It's located at the top of the kidney. So what is adrenal gland role? Usually adrenal gland releases two important hormones, cortisol and also the aldosterone. What happens in case of Addison's disease? This Addison's disease condition, immune system will attack this adrenal gland. Then the cortisol and also the aldosterone hormones production will be reduces, because the immune system cannot find out which is self, which is non-self. It will go and attack the adrenal gland tissues. The cortisol adrenal will be reduces. In that particular situation, the body will become very weak. You can see then the body produces the low levels of sugar in the body. They completely decrease the levels of the sugar levels. Cortisol will be reduced and aldosterone will be reduced. Sodium loss and also the excess potassium level in the blood. I'll give you the other opposite condition of this Addison's disease. Hope you remember. This is called Cushing syndrome. You know that. So complete opposite of this Addison's disease. High levels of cortisol and aldosterone is Cushing syndrome. That is another story, but just here we're going to differentiate the condition. I'm just explaining you. So Cushing is opposite, Addison disease is opposite. You can see the opposite conditions also, the little symptomatic condition. Addison disease condition, you can see the people, the one with the bending condition. They are very bending, very weak, weight loss, everything will be there. But whereas Cushing syndrome, you can see the bulged condition because of the opposite, weight gain, more constipation, more abdominal pain, more fat formation. These are the Cushing syndrome. Addison is completely opposite, weight loss. You can see the bending condition, spine not working properly. Lot of problems. Kidney functioning is also not that good. So this is about Addison's disease, one of the autoimmune disorders in the diseases. The next category, Graves' disease. This Graves' disease is related to the thyroid. You know that. Thyroid, which is located at the neck region. So Graves' disease, what is the definition of that particular one? Again, the immune system will attack the thyroid gland. Thyroid gland, each and every gland produces its own hormonal thing. What it produces? We all know that T3 and T4, thyroxine condition, TSH, and thyroid stimulating hormone. In this Graves' disease, immune system will suppress the production of the hormones. That means T3 and T4 will be reduces in the body. the suppression of the T3 and T4 production. It's about Graves' disease. You can see the bit of, Adam's apple, like a bit of problematic condition at they feel neck pain and more swallowing in the throat condition, dry mouth, a lot of complications with this Graves' disease. And next one is Sjogren's syndrome. The Sjogren's syndrome, which is related to the main barriers for our body, eyes and also the saliva, which is related to the immune system, attacks the lacrimal glands and salivary glands. We all know that in the autoimmune disorders, the gland suppression will be go down. So Sjogren's syndrome, the eye lubrication and the mouth lubrication will be go down. The salivary secretion will be reduced in the body because of the Sjogren's syndrome. Immune system will suppress the saliva production and the eye tears production. So we know that without tears and without saliva, what happens? Dry mouth and the dry eyes, common symptoms of Sjogren's syndrome, which attacks the main barrier of the human body. And the next one, Hashimoto's thyroidism, which is a bit related to the Graves' disease, not exactly, but it's an opposite condition. When you remember the Graves, you can just recollect the Hashimoto's disease as well. Because what happens in the Graves? Suppression. The Hashimoto's, more like a deficiency condition will be there. So, which is mostly related to the thyroid hormone production. It's a deficiency of the T3 and T4 conditions inside the thyroid gland, mostly relative conditions. And the other one, myasthenia gravis. We know that most of the patients, they blink their eyes like frequently. Myasthenia gravis is an autoimmune disorder actually. It's a common thing. We all know that. Indian film stars also, some of them, they have it. The music directors. We know that Keeravani. All Indians are watching and viewing a session. So we know that. The Keeravani, music director, you can see the blinking of the eyes all the time. So that is a myasthenia gravis. Immune system will go and attack the muscular condition of the eyelids and eye-related origin. So the muscle will be blinked all the time. They blink all the time involuntarily. They don't even know what's happening because the eye cells and the muscular things are contracting and dilating all the time by our own immune system. Again, what could be the reason? Obesity or any triggering factors, stress condition. These are the common risk factors for this myasthenia gravis. Coming to the other one, autoimmune vasculitis. We know that itis is nothing but inflammation, vascules, all the blood vessels in the body. Immune system attacks the blood vessels. So that contraction, dilation causes the blood vessel inflammation. That is about autoimmune vasculitis. And the 13th one is pernicious anemia. Anemia, we all know that. Reduces levels of hemoglobin in the body. So, but pernicious anemia is a bit different. But when you're taking the food will be absorbed by the gastrointestinal tract, especially with the intestine. So, in this condition, immune system go and attack on the intestinal flora that our food B12 will not be absorbed by the intestine. Vitamin B12 cannot bind with intestinal flora. That will be done by our own immune system again. The reasons are, again, any conditions related to the ulcerative condition or in the food skipping condition. At that time, the pernicious anemia will be caused. Immune system stops the absorption of vitamin B12 by the intestine. It's about pernicious anemia because a lot of anemia conditions will be there. All not comes under autoimmune disorders. The particular pernicious related to the autoimmune diseases. And the last 14th important one, the common autoimmune diseases, celiac diseases. Let's see, colon, related to the colon. So nothing but inflammation and the damage to the colon part of the flora of the colon causes the gastrointestinal problems. That means the persons who cannot tolerate the gluten. That's what we all see in the supermarkets, gluten-free food. And even for the infants and the toddlers, they sell the powders with the gluten-free. Some of them, they cannot tolerate the gluten. It's like a material, like a chemical component, which can cause some autoimmune disorders in the body. So that's what we have to be avoided, make sure, without gluten, which causes celiac diseases in the colon and the GIT, causes inflammation to the colon part. So this is about common 14 different types of autoimmune diseases. And now we'll see the common symptoms, very common symptoms of autoimmune diseases. When the immune response started, the symptom will be started, such as fever, hypersensitive reactions, and the rash. So likewise, fever is a main important common symptom of the any kind of immune response. And the other one, red red color patches on the skin, redness and the swelling, inflammation, muscle pain, joint pain, swelling, fatigue, that means you feel tired all the time, abdominal pain, digestive problems, and the butterfly shaped rash on the skin. We already discussed lupus, different from the psoriatic condition. These are the common symptomatic conditions to the autoimmune diseases. Because of the once response started, symptoms will be started to know that response is happening in the body. This is about common classification of autoimmune diseases, main things. Now, diagnosis of the autoimmune diseases. We all know that there is no specific single test to diagnose the autoimmune diseases. It should be combinative. So, before going to check the autoimmune disorders, they have to check the CPP conditions, complete blood picture, to check how much level of the WBC level, because these are the important heroes of the immune system. So WBC level should be monitored, and the body response should be monitored. Everything like joint conditions, the muscular pain, and the kidney level, and the uric acid level, and the liver functioning test, everything should be monitored. That's what it's a combination of tests should be done. But the main important test, the first important tool to diagnose the autoimmune disorder is anti-nuclear antibody test, because antibodies will be produced during this autoimmune disorder, because they produce more overactivation of this body immune system. So if the overflow of the antibodies, they will find out which kind of antibody released, either IgG, IgA, IgM, or IgE, which one is releasing. So depends on that antibody test, they will find out it comes under which classification. But anyway, we know that anti-nuclear antibody test is positive, means there is autoimmune disease in the body. So individual conditions has individual things, like such as rheumatoid arthritis. It's a C-reactive protein, very important thing. Along with this ANA, we have to do the C-reactive protein, because it will be raised in the body at the joint and the bones part. Overactivation of the autoimmune diseases with the positive. Next, treatment options for the autoimmune disorders. We all know that treatment should be categorized into two different sections: pharmacological treatment and also the non-pharmacological treatment. The treatment options, our third speaker is going to explain much about it, because it's an important role of the rheumatoid arthritis. You're gonna listen much about the detailed information about the DMRDs, disease-modifying rheumatoid arthritis drugs, and the immunosuppressive drugs, everything. But here I'm giving you an overview which is related to the introduction of my diseases and the immunity. The treatments are non-steroidal anti-inflammatory medications, because non-steroidal anti-inflammatory medications suppress the pain and inflammation, such as ibuprofen. It starts with the maintenance dose and the initial dose. Starts with 400 milligram, and it may reach to the almost 3 times a day. That means 400, 800, like that. We can improve until the maintenance dose. It depends on the severity and the pain condition of the person. Naproxen starts with the 500 milligram of the dosage. And the second category of the treatment option in the pharmacological is corticosteroids, prednisolone. We start with the dosage of 5 milligram. The initial patient should be start with 5 mg. It should be like a dispersible, the slow release of the medicine in the body. And the third important one, immunosuppressive drug, because all know that autoimmune is overactivation, cells depleted. So we have to suppress, slow down the condition. The main important one, methotrexate, very important for treatment for the autoimmune conditions. We'll start with the 0.2 milligram. It's according to the weekly condition. This depends on the dosage, depends on the patient severity and the patient's classification of the disease as well. So the main treatment focus is on the autoimmune diseases, calm down the condition of the immune response, like to normalize the functioning of the immune response. That's the target of the treatment. Now we'll see the non-pharmacological treatment of the autoimmune disorders. This is a protocol, what to eat, what not to eat. The foods to be taken by the autoimmune disorder patients, what they eat. Definitely we know that vegetables are a main important source for the immune system. But in this specific condition, the one with these condition, autoimmune disorder patients, they should not eat nightshade family kind of food. You can see the next line, nightshade. What is the examples for the nightshade? Tomatoes, potatoes, peppers, bell peppers, And eggplants. Eggplant is nothing but in our country we so use that brinjal. Brinjal is an eggplant, so we have to avoid. Why we have to avoid? What could be what's the main reason behind it? The main reason is, which all comes under Solanaceae family, the main alkaloid present in that particular nightshade vegetables, it's called solanine alkaloid. In this immune system overactivation, it will again overactivates the condition. Better avoid these things. Not only these things, the one with the sour condition, the sour taste food should be avoided. Like a tamarind, all this should be avoided in this situation because of the alkaloids overactivates the immune system again. Already it's activated. If you give such kind of food, it will worsen the condition. And the second category of the foods to be taken, high quality of seafood. So we all know that omega-3 fatty acids are essential for the body, immune system responding. And the third one, fermented food. Why we need the fermented food? Yeast is play an important role in the to treat the autoimmune disorders. It takes a long time to explain about the yeast, how it's going to be activates the immune system and how it responded with this, because yeast is an important food for the autoimmune disorder patients. And the next one, meat and also the liver food, which is a more proteinaceous food. So protein, normal proteinaceous, okay, not too protein, meat is important for the body. Small amounts of fruit, not too much, too much citrus also not good for the autoimmune disorder patients. It causes some citric acid conditions, not good, because with the treatment together. And the last one, oils such as olive oil, coconut oil, and avocado oil, also mostly with the extraction from the vegetables will be very good comparatively with sunflower oil. Olive oil is most effective for the autoimmune disorder patients. What to avoid it? As we discussed the first line, nightshade food should be avoided, tomatoes because of the alkaloid present in it. And the next one, pulses and the grains. A lot of lentils should be taken. More proteinaceous food. They just boost up the body energy, not the immune system, like a little bit amount to become fight against the conditions. Already the patches will be there, no, just to normalize the symptomatic relief of the grains. Legumes, and also the dairy products, milk and vegetable oils. Coffee should be avoided. Grains, again it will, legumes and the grains, again which will more proteins will be there. Already immunoglobulin is made up of protein. If you take that, it will, again, the proteinaceous binding will be more in the body. It may cause to the too much overaction. Better avoid, or very, very, very limited consumption should be there with these kind of grains. And the vegetable oil should be avoided. Caffeine should be avoided. Eggs, the nuts and the seeds, because all you know that nuts and seeds a bit containing of the gluten amount. You know that alcohol and the additives, which are like preservatives, added sugars. You know that sugar is a main medium to grow the microorganisms in the body and the pathogens in the body. Better avoid it. So these are the common protocol, what to eat, what not to eat for autoimmune disorder patients. Now it's our pharmacist role, the clinical pharmacist role towards the autoimmune disorders, and I can explain you in a journal way as well how it works, how the patient will be treated or the counseled by the pharmacist. Pharmacist care is very important. The doctor can diagnose the condition, but whereas the clinical pharmacist can care for the patients, because we care in different ways. That is, the pharmacist care outcomes categorized into 3 different sections: clinical, humanistic sections, and also the economic outcomes. The first 2 are very, very important for the pharmacist to produce the specific outcomes to the patient. What is clinical outcome by the pharmacist? Clinical outcome completely related to the patient health. So such as, what is happening to the condition? What is a disease condition? What is the health status? What is the reports that they have? What are the treatment what they are taking? How to take, what to take, when to take, what is the right dose? All these will be explained in the clinical condition, clinical outcomes of the pharmacist care. For example, I'll give you a simple example how to take the autoimmune disorder conditions. I'll take a simple example in this clinical outcome. I've got a patient with a asthmatic condition, but they have diagnosed with some particular autoimmune diseases. I'm taking a simple example to explain this pharmacist care. So this asthma is a disease condition, as we discussed earlier, because which is related to the measurable disease. Asthma is related to the chest. The one with asthma, how to treat this autoimmune disorder patient if the person is diagnosed with autoimmune. I cannot give non-steroidal anti-inflammatory medication to that person because non-steroidal anti-inflammatories can affect on the beta blockers. So again, it may worsen the condition. Before you start the treatment, what are the previous history conditions of the patient should be monitored. Asthma, you cannot give NSAIDs. You have to give the particular anti-inflammatory, non-steroidal, non-specific. That means you have to give the selective anti-inflammatory, which is not effect on the beta blockers. This is about one story. Coming to the other story, gastritis patient with autoimmune disorders. You cannot give again NSAIDs because again it may cause to the gastric trouble to the patient. It may releases the acids in the gastrointestinal tract, which can cause again big trouble to the gastrointestinal indigestion problem. Better avoid these things. We have to give the COX inhibitors, COX-2 inhibitors, celecoxib, etoricoxib, start with 90 mg. So this all comes under clinical categories. You have to explain the interaction of the medications, what they are taking, what in case of any warfarin condition, what not to be taken, aspirin condition, what they are taking, high blood pressure tablets should be monitored, should be checked. If any interval gap is there, that you explain. If there is no choice to take, give some frequency time. If not, how to take, how to skip, how to deal with the food. We all know that grapefruit juice or grapefruit, it's a citrus fruit actually. You cannot give such a medications along with that. It can cause some big trouble to the body. In some other international country, when I was studying, there was a big article regarding it. The grapefruit juice combined with some calcium channel blocker, the patient was died immediately. So food is play an important role with the medicine. You cannot take specific food with that particular medicine. This information will be covered in the clinical outcomes. What is humanistic outcomes? Humanistic outcomes are nothing but you improve the quality of life of the patient, because how you explain, we can make a questionnaire which has the 10 questions inside. What are the adverse effects you are observing with the treatment, and since how long you have been taking, and all these comes under humanistic. We can make a questionnaire. 10 questions will be there. Each question has some little scoring will be there, 1 to 10. So 0 to 100 questionnaire HRQOL. This HRQOL I'm not going to explain much because it's completely related to the vigilance department, but just I'm giving you the overview. HRQOL, quality of life, has a different scoring, 0 to 100. So it depends on the scoring. We can give poor quality of the life and acceptable, very good, or excellent. So it depends on the scoring. High score is excellent. So we can just make the patient being well. And the final outcome of the pharmacist is economic outcome by the pharmacist towards the patient. A lot of patients come to me every day. I deal with a lot of patients per day with a lot of symptomatic condition. But I have to make sure that patient should afford the medication, because he have to bear the cost of the medication as well. We have to cautious what kind of patient is coming to you. You cannot always give such an expensive medication with the people. You have to look forward. Make sure you have to be cautious with the patient, the way they look, the way they come to the pharmacy, the way they talk with you. These are all comes under economic pharmacist outcome. Me, I always care for the patients, definitely, because I have to make sure if the international or the foreign tourists come, I always give big amount, because sometimes we have to look after the business as well, but we have to make sure patient care also very important. Look forward the patient condition, how they talk, how they look, so that you can give just affordable or patient economic condition. You have to look for that, very important. This is about my impact towards the autoimmune disorder. I gave some examples regarding the clinical outcomes. And this one, common information about the managing autoimmune disorder by the pharmacist. I can resolve the drug-related problems. As we discussed, drug interaction should be monitored if any previous history or something. The next point is management of modifiable diseases. This comes under lifestyle modifications while patient counseling point, like avoid the smoking, avoid the exposure to the chemicals, just do some exercises, weight loss. All this comes under modifiable risk. And the next one, recommending dietary and lifestyle changes. Definitely, smoking condition, the lifestyle habits. Providing patient counseling, very, very important. We have to discuss each and every point about the medication to the patient, how to take, what to take, when to take, what's the frequency gap in between them. And the disease education, how it comes to you, because they need to know what happens in their body as well. You cannot give just a medicine. You have to explain what happened to the disease, why they got it, any other choices. And finally, medication advices. It just counsel the patient about the disease, about the treatment, just to in a other way. Reducing the out-of-pocket cost, as we discussed, patient effort is very important for their care. Finally, improve overall the quality of the life and the well-being of the patient, important one. All the autoimmune disorders are chronic conditions. They are long-term one, and it is self-medicated. So definitely you need pharmacist care rather than the doctor, because doctors and nurses, they need the injection form. Self-medication, you need more information from the pharmacist because they take orally. So hence, pharmacist care will have vital role and important role play in the autoimmune disorders to achieve best outcome healthcare. Experimental pharmacist interventions, what to intervene, because disease education, I have to educate the patient with the disease condition. This is about the general way, not related to the autoimmune disorders. Educate the patient regarding the disease, dietary and lifestyle modification, counsel the patient regarding to the adherence. Adherence is nothing but acceptance of the medication. Even though I counsel the patient, even though I give the medication to the patient, I can't go and see whether the patient is taking or not. But we have to make them to accept the medication. If they don't take the medication, it won't cure. So make sure, in case if the patient is not able to understand the condition, you have to explain to the caretakers also. If someone is come with the patient, you have to explain to them. Make sure adherence towards the medication, acceptance of the medication, taking the medication. Finally, advice on the medication use. As we discussed, right time, right drug, right dose, right frequency, and the right cost. This is about medication use. Finally, these are my references. I've got this information from the European Journal of the Hospital Pharmacy and also the Autoimmune Disorders, the National Institute of the Health. These are the common references of my information. Regardless to the autoimmune disorders, just with this world situation and all we are wearing masks, just boost up your immune system. COVID is giving hard time to everyone. I wish everyone is stay safe and just be healthy. So that's what boost your immune system. Apart from this, be happy and be healthy. This is my just logo to boost up the immune system with this COVID situation. We are fighting a lot with this virus. Hope it will be fun. And how to boost our immune system, because viral infection is nothing but low down the condition. It's not overactivation like autoimmune. COVID situation is more like deficiency. The immune system will be weakened by the fighting. So these are the common immune booster foods for us, like all the COVID situation fighting people. High zinc foods, vitamin C, probiotics, the boosters such as garlic and the natural food, and any kind of cinnamon, ginger, turmeric, and finally liquids. Any green tea and more water, drinking more water. It will flush out the viral things. There was something explaining with the situation. More fluids should be taken. Zinc is an important role as well. Antioxidant zinc, vitamin C, ascorbic acid. So these are the common, simple to boost up to fight against the situation. What we are facing, the current situation with this pandemic. Now it's going to be worse than the before. So make sure. Thank you all for giving such a good opportunity to me to finish this such an important session, autoimmune disorders, and also the role of clinical pharmacist. That means my role, what I'm doing every day. Thanks a lot. That's the session.
Thank you, ma'am. It was a very elaborated session.
Thank you.
So we have some queries, ma'am.
Okay.
One of such queries, like how long does the treatment last?
Okay, the treatment, it depends on the severity of the patient actually, and also the classification of the type of the disease condition. As we discussed earlier, disease and the disorder. Disease is particular condition. So this can be measurable, but whereas the disorders cannot be measurable. In case of disorder condition, they prolong the treatment. It depends on the diagnosis and the patient response, how they are responding towards the medication. We all know that age is an important factor. Age group, the 40 years and the 50 years, they cannot respond much. This 30 to 40 years respond faster. So treatment depends on the capacity, how we are responding towards the medication. So it depends on the situation. Any other queries, please? Unmute. I think Shivani, you are on unmute now. Sorry.
Yeah, thank you, ma'am. There's another question.
Okay.
Does COVID have any effect on autoimmune disorders?
Definitely, because COVID is nothing but viral infection. So autoimmune disorder, we know that it's a more overactivation of immune system. In this particular condition, if you take vaccine again, the body will fight more and more against that vaccine. So still the research is going on it. Still the information is not yet clear. The scientists are still working on it, because if the vaccine enters into the body with this autoimmune disorder patients, it will activate more. So some of the studies are saying that just better avoid during this situation until it controls. Because if you take it again, more complications will be there, definitely. I believe it's still going on.
Thank you, ma'am. It was a wonderful session.
Thank you so much.
I'll meet you again in another session, ma'am.
Thank you so much, Shivani.
That was a wonderful first session. Now let's move on to our second session. I would request Ms. Dharani, Assistant Professor, St. Peter's Institute of Pharmaceutical Sciences, to introduce our next speaker, Mrs. Shaili.
Good morning, everyone. I'm happy to introduce our next speaker, Mrs. Shaili Makula, pharmacist, North Carolina, USA. Currently, ma'am is in maternity leave. She did her Masters of Administrative Sciences in Global Health and Human Services Administration from Fairleigh Dickinson University, Vancouver, BC, Canada. She also done Masters in Pharmacy Practice from St. Peter's Institute of Pharmaceutical Sciences. Ms. Shaili also served as ex-editorial assistant for Indian Journal of Pharmaceutical Sciences for 2 years. She has 2 years of teaching experience in St. Peter's Institute of Pharmaceutical Sciences. She has delivered various oral presentations, posters at many conferences. She has worked on various projects and published national and international publications. It's a pleasure to have you among us, ma'am. I welcome you to start the session.
Thank you so much, Dharani. That was a warm welcome for me. Firstly, is it audible?
Yes, ma'am.
Yes, ma'am, it is audible.
Yeah, I feel very happy to be back on board with St. Peter's. Yeah, it's been a while that we were on this board of explaining, discussing about the topics that we have already learned, worked in. And it really feels me like my energy got boosted up 10 times, coming back on board. So without wasting any time, I would like to dive deep into the session today. So from my end, my topic is role of clinical pharmacist in the management of type 1 diabetes. So let's see how it goes. So before going into the session, I would like to thank few people who really made difference in my life, both professionally and personally. So among them, thanking my parents, family, and husband. Apart from them, I would sincerely pay my gratitude and thanks to Dr. Jaipal Reddy Garu, our chairman, Dr. Rao Vadlamudi Garu, who is my first guru in my career and as well as a professional experience. And then our beloved principal, Dr. Rashekar Garu, and not the least, but not the he is like the backbone and pillar of every event that happens in our institution. Nandu sir, I really have to thank him. That's all. And whatever I am today, or whatever I achieve in my future in coming days, I would owe my thanks and gratitude for all these people, because they have a remarkable and considerable contribution in those achievements, and I thank them at every single point of my achievement. So let's start our session. Okay, just a moment. Yeah. So is it audible? Is it audible?
Yeah, ma'am, it's audible and it's visible. Can you put a, yeah.
So, is it clear?
Yes, ma'am, it's clear.
Okay. So, as the title says, that the complete role played by a clinical pharmacist practitioner in the management of type 1 diabetes is a present topic for me. So, without wasting my time, I would like to know the let you know the objectives of today's presentation. So, what my intention is, by the end of this particular session, every person who is aware and unaware about this particular type 1 diabetes should be able to understand what's going on actually with type 1 diabetes. So, the objectives of this session include to have the brief understanding of type 1 diabetes and role of clinical pharmacist in its management, to explore the scope of clinical pharmacist practitioner in maintaining it or managing the above condition, to know the facts and assumptions of clinical pharmacist role, and last but not the least, the important one is that goals to improve the quality life of the patient. So before diving into any particular topic, we should know what actually it is. So diabetes is a chronic, that means a long-term metabolic disease characterized by elevated levels of blood glucose, which leads over time to a serious damage to heart, blood vessels, eyes, kidneys, and nerves. So this particular diabetes is not a single disease alone. It is a pathology or pathophysiology characterized by a multiple things that are happening in the body and the metabolic things that are going into changes. So these include two types, basically into two types. Other than these two types, there are other diabetes which are minute contribution. So the major types of diabetes that are causing hell out of the world are type 1 diabetes and type 2. So type 1 diabetes is once known as juvenile diabetes because it is mostly seen in the children, younger children, and younger adults who are less than 19. Once known as juvenile diabetes, or it is insulin dependent diabetes, because it is a chronic condition in which the pancreas produce little or not enough amount of insulin. Type 2 diabetes is usually seen in adults, and this occurs when the body becomes resistant to the insulin that is produced within the body, or the body itself doesn't make enough insulin. So these two are the very, very rough and brief idea about two types of diabetes. And today's our topic is about type 1 in specific. So, what actually is about type 1 diabetes? As I said before, type 1 diabetes is a condition wherein the body of a particular person who is aged between 6 to 19, or even it is seen in some infants also, very younger age children also. Um, so, it's a condition wherein the body is unable to produce the enough amount of insulin because of the inability of the pancreatic cells of that particular person. So why does this happen actually? Means in some points or at some point of time, in some patients, their immune system itself will try to consider or mistakenly considers the pancreatic cells of that particular person as foreign bodies. So, as our defensive or immune mechanism is in general produce antibodies whenever it finds a foreign body within our foreign antigen within our body. So, as a part of this defensive mechanism, by mistakenly understanding the pancreatic cells as foreign antibodies, it started to show its defensive mechanism. So, the defensive mechanism cells in our body are WBCs. So, these white blood cells show their defensive mechanism on the very healthy, active pancreatic beta cells. So, what results with this process is that the beta cells wouldn't be able to produce the enough amount of insulin, which is actually required for a person. To actually gain the energy. So, what this particular insulin is essential for means insulin is one such hormone which converts the entire carbohydrates. So, carbohydrates means the rice, sugars, fibers, whatever the dietary intake of these particular components enter into our body will be metabolized into glucose. Okay, this glucose has to be taken up by the cells in order to convert this glucose into energy. So whatever the mechanism of conversion of the glucose into energies happens within the cell. So in order to facilitate the entry of glucose into the cells, this insulin hormone acts as a key with which the glucose which is wandering in the bloodstream will be taken by the cells, and then it will be converted into energy, and that energy will be used for different types of activities within the body. So because of this mistaken defensive mechanism of that particular person's immunity, the beta cells wouldn't be able to produce this hormone, because of which insulin is not available, because of which the glucose or the sugars that are available in the bloodstream gets precipitated and the concentration goes on increasing. So this is the pathophysiology and why it causes or why it occurs. So there are two types of factors that contribute for type 1 diabetes, or deprivation of insulin, or attacking for the beta cells, or any mechanism you take in this entire path of type 1 diabetes. So those two factors are risk factors and causative factors. What are the risk factors means? Risk factors are those which are assumed, which are probable. So they might or might not cause type 1 diabetes in if you take a single specific person, but they are assumed to cause the type 1 diabetes. Coming to the causative factors, these are the exact factors or exact reasons which actually result type 1 diabetes in X person. Okay, if you consider X person, so causative factors are the direct exact causing causative factors, and risk factors are those which are probable and which are assumed to be. So, in whom this type 1 diabetes is usually seen? It is usually seen in children, young adults, but exceptionally it is found in different ages of people also. So, coming to the prevalence. So, before knowing the prevalence, how important it is to be for a clinical pharmacy practitioner to pay attention means, yes, it is, because there is a heap or the ongoing increased number of cases in the diabetic condition patients. So the prevalence of this particular type 1 diabetes is 10% of all the diabetic patients. So how we can rule out the situation? Usually, there is a myth that until the situation gets worsened, nobody will be aware about what's going on in their body. Same like that, until the onset of symptoms in a particular person, he or she wouldn't be able to figure out what's happening with their bodies. So once they experience it in symptoms like deprivation of energy, or excessive thirst, excessive hunger, these kind of unusual symptoms, then they would definitely visit a physician with the recommendation of whom these diagnostic tests are performed. Among those, first one would be fasting glucose test, random glucose test, and A1C test, which we call as HbA1c test. So, as the name says that fasting glucose test and random glucose test are those tests with which done by in which the amount of glucose present in the bloodstream would be detected, and the ranges are as follows. The normal range would be less than 100 for fasting glucose and less than 140 for random glucose. And if it exceeds beyond that, it would be divided into two different conditions, as pre-diabetic condition and the diabetic condition, as per the numbers given on the table. Coming to the third test, this is A1C or HbA1c test. Actually, this test determines how much amount of sugar is present in the blood, because if the amount of glucose increases in the bloodstream, it keeps on the every molecule of glucose keeps on getting attached with the hemoglobin molecule with the oxygen protein bonding. So this is how it actually the glucose gets attached with the hemoglobin. So as we measure the amount of hemoglobin with sugar, we would be able to determine the amount of glucose within the bloodstream. So the recommended level will be less than 7%, and it would be much better if it is less than 5.7%. And if it is 6.5 or 7% or more, then it would be considered as a diabetic condition. So once the diagnosis is done, it's very important to go into the treatment. So in the treatment, first would be diabetic ketoacidosis, because by the time a person comes and visit a physician, or started to experience the severe symptoms, by the time it's been a while, and by that time where he experiences the symptoms, this particular condition called diabetic ketoacidosis will start progress, and it will be in its process. That's the reason first the physicians or the pharmacist, by looking their reports, or the lab technicians, whoever conducts the results, will check for diabetic ketoacidosis, where there will be higher amounts of ketone bodies within the body of that particular person. You know, as there is no insulin to actually give the energy to the person. Like, there is no insulin, no breakdown of glucose into energy. So that's the reason the body tends to replace this energy with other forms of energy from the body, that is the ketone bodies. So the number of ketone bodies increases, so it results in ketoacidosis. So the treatment for this would be fluid replenishment or fluid replacement and insulin therapy. Coming to the actual treatment of type 1 diabetes, it would be insulin therapy. So among this insulin therapy, there are different types of insulin regimens that are effective for type 1 diabetes, as the condition itself is very specific about insulin insufficiency. So the therapy itself relies more on supplying the insulin in different forms. So the basic and primitive one would be insulin syringe. Other forms would be insulin pen, and the latest and most effective, I would say, the latest one, the most effective, and the most expensive one would be the insulin pump. So coming to this insulin regimens, they differ from patient to patient, and they are completely patient specific. So before rushing into the treatment, everyone would get a doubt that why can't insulin be given as a pill, or the easiest form of medication with which nobody would have any complications. The basic reason is that insulin is a peptide hormone. So if we formulate in the form of a pill or any medication, then that would be easily broke down into smaller proteins as soon as it enters the body before the absorption. So that's the reason this should be given in the form of either subcutaneous form through syringes, or IV form, if in the case of diabetic ketoacidosis, and in case of emergencies also. So the insulin regimens include different types. Among them, I would like to give a rough idea of insulin regimens. They would be rapid acting, intermediate acting, regular, and the long acting insulins, depending upon the condition of the patient. So other treatment approach would be relationship between the metabolic control and complications in diabetes. So it's very important that while you treat the condition that the patient is going through, it should also be taken into consideration that how his body or her body is reacting to that particular treatment, and what kind of metabolic changes that are going in his or her body should be taken into priority. Otherwise, it's like a one-way thing. We keep on, or the physician or the medical team or multidisciplinary medical team will go on treating the patient without having a concern about what's going on in that patient. Then it would be waste, and it won't give the effective results. So for that reason, the metabolic control, the metabolic changes, and his response to that particular treatment should be evaluated along with the treatment. And this also leads us to important fact that the complications in the diabetic patients can also be minimized if we have a proper evaluation of the therapy and outcome from the patient. So that's the reason the relationship between the metabolic control and the complications in the diabetes are to be taken into consideration in the treatment protocol. Next, we next option is like open and closed loop insulin delivery systems and glucose sensors. So here, this sounds really interesting that there are different types of insulin delivery systems. One is open loop, and the other one is a closed loop. Open loop is something that when you administer the insulin, it has to be from the external source, and it's not automated. So the example under this would be syringes, And the closed loop insulin delivery system is one such thing wherein the system is completely automatized. It reduces the human effort and it is more efficient in case of any emergencies. So this in this particular closed loop system, the glucose amount evaluator, the algorithm at which the insulin has to be delivered, and the way through which insulin is delivered, all the three segments are interlinked and framed as a single system or single unit system. So that is the reason this is considered as a closed loop system. And closed loop is sometimes called as artificial pancreatic system, wherein the artificial pancreas, like this entire system is uh, placed within the body of the patient, or sometimes the entire pancreas is being replaced if we get a healthy pancreas well in advance. And if there is any lack of the donor or availability of the healthy pancreas, there is another approach for this closed loop insulin delivery system, is that they try to reverse the functioning of the pancreas through natural process. But this is very rare and it's not effective, and there are no reports that it's been effective since ages. So the this is all about the closed and open loop insulin delivery systems. So what is the glucose sensor thing is that before starting any kind of treatment, you should actually, or the healthcare team should actually assess the amount of glucose within that particular patient. So only when the glucose is estimated, then only you can actually start or think of starting any approach to treat that condition. So for any treatment to be initiated, the amount of glucose present in that particular patient's bloodstream is very important. So that would be achieved by using glucose sensors. So glucose sensors can be self-monitoring glucometers that are available readily in the market, or they can be continuous monitoring systems that can be attached to the body as a subcutaneous and transdermal things. It can also be an automated app that actually takes the sensor like sensory thing. But the last approach is still in process and the clinical trials are still going on, because it's too much automation in that particular concept. So next option is like next treatment option, or I can say this is a follow-up along with the treatment of the type 1 diabetes, that is educating the patient and the family with type 1 diabetes. So anybody who encounters a situation wherein they or their family members are diagnosed with type 1 diabetes, so definitely they would feel panic and they would start worrying because it's a long term thing. So before if possible, you know, in quotes, if possible, the clinical pharmacist or the physician, whoever present in that multidisciplinary clinical team, they has to educate the patient, they has to make them understand that it is normal, that it's common and it can be managed. So there is a saying that it's not fun having diabetes, but a clinical pharmacy practitioner should make sure that the patient should have fun while having diabetes and while he is or she is a diabetic patient. So, keeping that in mind, the clinical pharmacist practitioner should give enough information, enough awareness, and the effective awareness about the particular condition and the things to be done, and the follow up to be done, and the evaluations to be done for that particular patients to, manage the condition. So, last step along with the treatment would be nutritional management. In type 1 diabetes, nutrition diet plays a very very major role, because entire thing of this pathophysiology runs around food, and that food, when it breaks down into glucose, then that is causing the problem. So nutritional management is very important. And the carbohydrates, which are a combination, usually the carbohydrates are of three types: proteins, fibers, and sugars. So as much as possible, the sugars and the protein sugars, especially the sugars, should be replaced with protein and the fiber. So first priority would be fiber, then would be protein as per the requirement of the patient, and least would be the sugars. So, what are the goals of the treatment? Our major goals should be like no symptoms or discomfort in everyday life, good general health and well being, normal growth and development, normal schooling and professional life. Because whenever a group of kids know that a particular kid among themselves are having type 1 diabetes, as they don't have enough information about the condition, they start to creating an uncomfortable environment for that particular patient or the child who is having. So, in order to avoid this, we should educate the child so that he or she will share her or his knowledge to the friends or fellow mates, so that it would be an effective way of having a righteous discussion also, and it will ease the child to have a comfortable life as usual and normal. So, normal family life, including the possibility of pregnancy and even prevention of long term complications. Hello?
Yes, ma'am.
Yeah. Sorry for the disturbance. A
Yeah.
small technical glitch in my audio. Coming to the role of clinical pharmacist. Is it audible? Hello?
Yes, ma'am.
Yeah. Those are the goals of treatment. And coming to the role of clinical pharmacist. So this is a most important or core topic for this session, the role of clinical pharmacist in management of this type 1 diabetes. Hope there is a little brief intro about what's happening with the type 1 diabetes. So what is our role in managing this chronic, painful situation, socially painful situation. So the role of clinical pharmacist include various sections where we have to concentrate. So first one would be interim therapy visits, second is patient education, third one is adherence monitoring and counseling, fourth one would be health barriers assessment, fifth one is prevention screening and maintenance, and sixth one is quality improvement. So let's dive deep into each. Interim therapy visits. These are the visits which are specifically chosen by the patients sometimes and recommended by the physicians sometimes between the patient and the CPP. CPP here is the clinical pharmacy practitioner. So he is the person who can actually have the power and ability to alter, monitor, and evaluate the patient's condition in accordance with the physician or doctor, whoever treats that particular patient. So these visits usually are to be scheduled for every single patient, but unfortunately, because of many barriers, it's not possible. The first and foremost barrier would be the trust on a clinical pharmacy practitioner. That nowadays it's been evolved that a clinical pharmacy practitioner will be able to do all the things, but previously there is a myth that he will be only assisting the physician but not capable enough to actually interpret. So that has been gone now, and now people evolved with their knowledge, intervention, involvement. So the first barrier that I've found would be the recommendation from physicians to the clinical pharmacy practitioners, and second barrier would be lack of interest from the patient perspective, and third one would be the lack of proper location or space for them within the hospital setup, wherein the interaction between the patient and the clinical pharmacy practitioner would lack the privacy. So what is the importance of this visit means? It's very, very important for one person to actually discuss what he or she is going through, and it's very important to know about what's their health condition and how can it be managed. So that's the importance of this visit. And in this visit, there will be a lot of scope for discussion, knowing the unknowing terms, and applying whatever they have known in their daily practice. So, because of this visits, the outcome would be a very effective management of their condition, like proper usage of given therapy, proper dietary control, proper exercise, and overall outcome would be like effective management of their condition. Next one would be patient education. The name itself says that education is very important. Education alone doesn't mean the lump sum of knowledge, but it's all about understanding whatever they listen. So it's really important to convey an understandable information, easy way, and better way for the patient in layman terms, rather than quoting them all the technical terms. It's very important for them to know actually what's going on in order to avoid unwanted complications into effect to achieve effective management. And it's also important that when a patient knows better about their condition, he can do much better than uh, other multidisciplinary team members or clinical team members, as that patient himself or herself would be very close to them. So they will be a closest enough person to watch their ongoing process in a daily basis, and they are the a primary healthcare person that is available for themselves. So it's very important and necessary that each individual or each patient who is going through this condition should be aware about this condition, its treatment, its management, and non-pharmacological therapy as well. So what are the barriers in this patient education concept is that less scope of interaction with the clinical pharmacist. As I said before, the patients are not able to communicate with the clinical pharmacy practitioner on a regular basis. It might be because of unawareness about these visits, and also lack of interest, and no proper proper protocol to take an appointment or meet the pharmacist. And sometimes it might be because of the cancellation of the visits. People do have lot many jobs other than their health, so obviously there will be cancellation. So this is also a barrier. So, what are the areas and scope for this patient education means? We can see like four W's concept: where, when, who, and whom to be given. So, it can be like these areas or scope would be an interpretation and intervention, I must say, because if the physicians and the hospitals or the clinics that are running nowadays, if they pay attention to this particular concept of patient education, so they can have a separate section for a patient education um, area. And in the hospital itself, when the patient comes to the physician, there itself an additional appointment of 40 minutes or 30 minutes would be allocated for this patient education. So whom should be given is that the patients and their family members need to be educated. Sometimes the discussion about the topics and sharing the knowledge among the team members is also required, because as the days progress, new information comes in and lots of changes will be there in the available information. Who will be giving this information means the clinical pharmacy practitioner who is well versed with the knowledge and practical experience is the right person to give this education. Coming to the third one, it's adherence monitoring and counseling. So, adherence is something like sticking on. So, whatever might be the patient's condition, or whatever might be the physician's therapy towards that particular patient, it's the patient himself need to pay attention and stick on to that particular regimen in order to treat his condition. So, as our first speaker said, that whoever the physician prescribes, or whoever the doctor prescribes certain medications or therapy, he or she wouldn't be able to go and observe the patient on a daily basis, right? So, it's the patient who has to involve and take interest among regarding this therapy, adherence, evaluation, and outcomes in order to make his condition or her condition better. So there the adherence plays a major role. So it can be assessed during combination of available resources, including a patient review and review of prescription filling practices, wherein actually the clinical pharmacist practitioner have a lot of gray area where he can actually come in contact or interact in a one-to-one basis with the patient, where he can ask a lot of questions and he can get righteous information about the usage and the practice that the patient is following. And also he can adjust the doses and the tests, additional tests if any, if the patient requires. And it also aids in effective communication and a bond, a proper knowledge sharing bond between the clinical pharmacy practitioner and the patient. So, clinical pharmacists include in each visit an assessment of patient adherence. So, this assessment would include certain questions like about their diet, timing of the medication, checking the glucose levels within the blood. Likewise, not only to the medication therapies, but also to blood glucose monitoring and lifestyle recommendations, which include the dietary changes and all, dietary intake. So, the clinical pharmacist advise patients regarding ways to improve adherence via such tools as simplified therapy dosing schedules. So, these dosing schedules are specific for specific patients. It can't be same for everybody, even though we follow standard protocols in dosing. So, every single patient is unique and different. So, these dosing schedules will be specific for specific individuals. So here comes the role of a clinical pharmacist, where the clinical pharmacist has the scope and area to actually intervene with the dosing schedules of individual different patients, and understanding different types of response of different types of people to the same treatment therapy, or same therapy. So, what are the assumptions of adherence monitoring and counseling? The assumptions include that yes, patients do follow. Yes, the clinical pharmacists do give the information. So, these two are the assumptions. What is the practice? Practice is that in general, only 50 to 60% people are interested in knowing about what's actually happening, and rest of the people are just concerned with taking the therapy blindly without following any kind of involvement, as they were worried, they are panic, and they are little depressed. So what is the current scenario about this thing is that the current scenario is we, being a clinical pharmacy practitioners, are trying to allocate certain space between the patient and the clinical pharmacist in order to get the things better, in order to achieve an effective management, in order to reduce the number of cases, and also to establish the importance of clinical pharmacist, which is being ignored. So the clinical pharmacist also trying a lot, practically, theoretically, through sessions, through various kind of platforms like online platforms, pamphlets, giving cards regarding the information. Likewise, the CPPs are trying, the clinical pharmacy practitioners are trying to intervene, provide, and help the multidisciplinary clinical team within the hospital. So they are trying to prove their mark, and this is what happening in the current scenario system. And yes, it's already been established, and we, being the clinical pharmacists, are having enough examples and enough exposure to actually deal with this kind of monitoring, counseling, and evaluating the management of type 1 diabetes and other autoimmune diseases. Not only autoimmune diseases, but any kind of a medical condition. Next would be the health barrier assessment. So, in general, whenever a patient comes to a doctor with some problem, usually that particular condition is being addressed. Along with that, what a clinical pharmacy practitioner can contribute is that they actually contributing, and they're also doing it. They will also do, and as of now, they are doing it. So, is that they assess the previous health condition of that particular patient, they assess their demographic profile, health conditions, comorbid conditions, and they try to assess is there any barriers in order to achieve effective management. and they try to interpret and they discuss it with the team so that the treatment or therapy that will be chosen would be the effective one. So the barrier for this would be psychosocial or health literacy issues, wherein the patient wouldn't be aware enough about their condition, so blindly they will ignore the things happening within their body. So the psychosocial and health literacy issues are often identified as barriers to appropriate self-care, and addressing such barriers can be more challenging in the context of shorter visit times. So if the visit time would be little more, other than this 30-minute or 40-minute window, then the clinical pharmacist practitioner would be able to actually discuss in depth about each other comorbid condition, and therein by there will be establishment of a bridge between all the conditions and their management. Simple miscommunications compounded by specific patients inability to navigate the healthcare system or advocate for themselves within the complexities of the system is also another barrier, which means miscommunication, misunderstanding of one thing for the other, and incomplete information, inappropriate information, unauthenticated information. So all these right away lay as barriers for proper assessment. So that would be definitely avoided by the presence and role played by the clinical pharmacist practitioner, because for years together they will be learning and they will be having practical experience, and also they will be working as interns in this particular areas. So these barriers would be completely eliminated with the presence of clinical pharmacy practitioners. So other barrier for health barrier assessment would be lack of privacy for communication, because in certain situations the patient will be interested to discuss, provided the area where they discuss would be not that comfortable for him or her to actually have a conversation with the clinical pharmacy practitioner, which is actually hindering the visit time and also the hindering the option of having a visit itself. So these are the barriers that are to be assessed, confined to the health of the patient. So with which we can actually achieve the effective measures that are to be followed. Coming to the other thing is like prevention, screening, and maintenance. So clinical pharmacist visits include a focus on prevention, including making medication therapy modifications and to assist the patients in achieving blood pressure, lipid goals, as well as laboratory monitoring associated with these medication adjustments. So not only the medication, not only the therapy, and not only the lifestyle modifications. Addition to all of these, a healthcare professional or a clinical pharmacist from the gross tries always to have a to find, to elucidate the preventive measures or the measures which will definitely cessate the problem, and they also would stop aggravation of the problem, and they would definitely lead to betterment of the patient's health. So as a part of it, the clinical pharmacist will be always ready to look into other comorbid conditions or complications that are being resulted with the type 1 diabetes thing in these patients. And also along with this type 1 diabetes, as it is a combination of other pathologies that are pathological changes, or I must say metabolic changes within the body, all those metabolic changes will reflect in different types of conditions that are unusual. So all those unusual situations will also be handled by a clinical pharmacist in these visits, with the reports that are obtained, and if any additional tests are required, he can actually modify and adjust and alter the actual prescription also. So additionally, the clinical pharmacist work to ensure other things like food exams, eye exams, vaccinations, etc. Because I personally seen a condition or a case where one of my friend's friend, she's a girl and she is a youngster. She actually felt very panic about her situation, and she was a little uncomfortable taking insulin whenever she went to college. So eventually she stopped doing taking insulin, which resulted in the amputation, or which resulted in the her foot problems, and they were so worse that three of her leg fingers, I mean foot fingers, were amputated. So these kind of situations also happen where the patient, him or herself, is not aware about the information, or they don't know how to handle their condition, and they don't know how to cope up with the situation. So that would be avoided with the intervention and involvement of the clinical pharmacy practitioner. And this can be achieved by counseling regarding insulin therapy and its management. And as I said before, it's not fun having diabetes, but definitely for sure a patient having diabetes can have fun, and that would be definitely you know propagated or whatever. It can be achieved only with the intervention or involvement of clinical pharmacy practitioner. Last but not the least, it's quality improvement. So whatever might be the diseased condition, entire team of this clinic multidisciplinary clinical team, which we usually quote as a physician, a pharmacist, a CPP, a lab assistant, and nursing staff, all these people will definitely try to improve the quality of life of that particular patient, no matter what might be the medical condition he or she is going through. So that can be achieved with the proper follow up. First, proper diagnosis, proper information, uh, or evaluation, and then a right years a follow up is required. All the three can eventually result in efficient quality of life of that particular patient. So this can be achieved through enhanced patient and pharmaceutical care, which involves obviously with the focused time. Uh, Now there is a situation in the present day world that clinical pharmacy practitioners are ready to give their time, their experience, their knowledge, everything. But people, because of unawareness and because of various other barriers that I've mentioned earlier, the platform where they can actually have interactions with the CPPs is lacking. I hope that would be also resolved, and it's resolving slowly, but sooner it will be completely resolved, and clinical pharmacy practitioners would definitely play their mark, and they would play their role in an effective way, in a global way. So other thing would be feedback regarding local register database used for population management of patients with diabetes. This includes registry maintenance of a database registry, because database is something that serves as a knowledge stock for us, wherein we can actually grab that information whenever required and interpret with the ongoing results or ongoing cases, and we can try to figure out what's happening. If something new happens, then it would be an additional information. So that's how it can be collectively collaborated and used in order to give an effective management in that particular condition. So overall chronic care maintenance would be like this. As the type 1 diabetes is a chronic ongoing condition, so it has to be managed. Management includes like it's lifelong thing. Insulin therapy is lifelong thing. Apart from that, what has to be done is that history and physical examination. They include blood pressure, BP checkup, body mass index checkup, review of glucose levels, and if the patient is a smoker, then smoking cessation plays a very major role. All these things would be for every visit. And other things include contraception or preconception planning, depression screening, because depression, even though it's minor, I mean it seems like minor, but it has a huge impact in quality of life. So depression screening, foot examination, dental examination is to be done, and depression, foot and dental examination would be done annually, like once in a year. But I personally prefer the depression screening should be done for every 3 months, because nowadays, because of various situations that are happening around the world, depression is a chart topping thing that can occupy anybody's mind. So it has to be done for every 3 months if possible, if not annually. Other laboratory tests would be HbA1c level, urine albumin creatinine ratio, lipid profile, thyroid stimulating hormone level, screen for celiac disease, liver function tests, and creatine level. All these laboratory tests are recommended because chronic diseases usually result in other complications. So, in order to rule out other complications and their situation in that particular patient, these tests are recommended. And these are not like compulsory for everybody, these are specific for specific patient. Like if you observe any kind of disturbances regarding thyroid gland, or the patient reports any symptoms or complaints about any condition, then these tests are to be done. Or as a preventive measure also, these can be included in the laboratory tests. Coming to the vaccinations, pneumococcal polysaccharide vaccine, influenza vaccine, hepatitis B vaccine, and other vaccines should be given or taken by the patient, because vaccinations play a major role in actually improving the immunity or providing the immunity, as it is an autoimmune disease. And type 1 diabetes sometimes also results because of viral infections, and sometimes because of unexpected injuries as well. So these viral infections or other infections, for those things, the vaccines play a major role, and they aid as a shield for those patients who are already vaccinated. And if the patients are not vaccinated, even in their late ages, they are ready to get vaccines based upon their other comorbid conditions. So other things include the management of diabetes, is education and dietary plan. As I said earlier, the dietary plan for type 1 diabetes plays a really major role. Among that, carbohydrates cut down, which means you have to minimize the carbohydrate intake and maximize the fiber, protein, and good fat content. So among those, good carbohydrates include fibers, good sugars, or if the person or the patient is more into sweets or sugar kind of things, those can be replaced with healthy fruits, where they fulfill the desire of having some sugar substances. So other things would be replacing the white rice or any this high carbohydrate or high glucose content food stuff with a good glucose or good carbohydrate content food, just like replacing white rice with other millets and grains, whole grains, etc. And occasional dietary intake of their cravings is also necessary, as it is insulin therapy that plays a major role. Once the patient shifts from automated regular syringes to automated system, just like pumps, these pumps actually they do their job, which means they automatically assess the amount of glucose, as per which they follow the algorithm of releasing the insulin into the body, with which, as they take any kind of inappropriate food into their body, the system, or that particular closed loop of insulin delivery system recognizes, and it itself automatically releases the amount of insulin that is required. So thereby there wouldn't be any other complication. Other thing would be assess of disease burnout. So whenever any person gets treatment for any particular condition, it's very important that we need to assess the burning out of the disease as well. Like what's the distress scale, or on what level is the patient in the scale of distress, how he's responding, and do he have any other socio-physiological or psychological concerns for her or his treatment should be evaluated. So all these together in a proper place as a team, the clinical pharmacist practitioner can collect, collaborate, and propagate righteous information with the patient and their family members. And this would definitely result in a proper chronic care maintenance in autoimmune diseases which are chronic. So, coming to the conclusion, in a nutshell, the type 1 diabetes is a chronic disease, and it has a traditional approach for its management, which includes insulin, exercise, and diet. Apart from the traditional approach, the present day modern approach would be insulin therapy, lifestyle modification, constant assistance. And I would like to add a small cornerstone for this traditional modern therapy is that a lot of love, care, and support is required in present day situations in this pandemic. And all this together would definitely give the patient what he required, and it also improves the quality of life. And this can be possible very effectively with the so-called title holder clinical pharmacist, who is defined as a licensed pharmacist who is approved to provide drug therapy management under the supervision of a licensed physician, which may include ordering, changing, substituting therapies, or ordering tests. So, after all this, what I strongly believe in is the ability to think differently today than yesterday is what separates the wise from the stubborn. So, let's all think in a different way, see the clinical pharmacist in a different dimension or perspective, and let's understand the value that they add to the health system or this entire health department. And let's collectively give a better life, create a better life, and create a better world wherein everybody will get a better services. And yes, we are ready. That's all my presentation. Hope this would add little value for this session. Thank you.
Thank you, ma'am. That was a very detailed explanation of the disease, ma'am. I have a query, ma'am.
Yeah.
What are the best strategies of the treatment that have to be given in type 1 diabetes?
Okay. The best strategy would be basal bolus strategy. Usually, it's not about giving a basal insulin, any one insulin, rapid acting, intermediate, or short acting. Rather than giving individual insulin types, it's always better, and the effective one is basal bolus insulin, wherein they give first long acting insulin, which is in combination with the rapid acting insulin, with which it mimics the action of usual healthy pancreas. And that's how the body doesn't feel that there is a deprivation of insulin, and it regularly functions as a normal pancreas. So the basic strategy is based on bolus insulin strategy.
Okay. There is another question. So, what is this open and closed loop insulin delivery technology?
Okay, close. The open loop insulin delivery system is something that which we usually take as syringes form, or the patient takes in the form of syringe, through syringe. And other one would be the closed loop system, wherein the pancreas itself is transplanted, or the automated system includes identification of glucose level, the algorithm for which how much amount of insulin is to be delivered, and the pipeline through which insulin is delivered into the body. All the three systems are together collectively categorized into one system, that is the closed loop system.
So, that was a delightful session, ma'am. Meet you in another session, ma'am. Thanks
Sure.
for
Thank you so much for the opportunity. Thank you.
So, moving on to our next session, I would now request Dr. P. Ranade Chowdhury, Assistant Professor, St. Peter's Institute of Pharmaceutical Sciences, to introduce our next speaker, Miss Dr. Sarumati ma'am.
Good morning, everyone. Our next speaker for the day is Dr. S. Sarumati, M.Pharm, MBA, PhD, Associate Professor, SRM College of Pharmacy, Chennai, Tamil Nadu. She completed her PhD in the year 2020 in Wales Institute of Science, Technology and Advanced Studies. She has a teaching experience of 11 years. Her areas of interest are teaching, clinical research, drug information services, pharmacovigilance, healthcare services. She has guided 21 PharmD and PG projects. Dr. Sarumati has 37 research publications in national and international journals. The Tamil Nadu Pharmaceutical Sciences Welfare Trust has awarded her scholarship for securing third rank in her M.Pharm project work. She has guided many other scholarship projects. She has given a guest lecture for online GPAT classes organized by Indian Pharmacy Graduates Association. I am very much pleased to invite you, ma'am, for this session. Thank you.
Thank you, Ranadi. It was a warm welcome. So I would like to thank St. Peter's management, HOD, principal, HOD, and convener for giving me this opportunity to be a speaker in this session. And also I would like to thank SRM management and our Dean ma'am for giving me this opportunity to be a speaker in this session. Is my voice audible, ma'am?
Yes, ma'am, your voice is audible. You can start the session.
I'll start sharing the screen.
Okay.
Is my screen visible?
Yes, ma'am, it is visible.
Okay. Okay, good afternoon all. So today my session is role of clinical pharmacist in the management of rheumatoid arthritis. So you know rheumatoid arthritis. So it is a chronic inflammatory joint disease. So most common typical features of this rheumatoid arthritis is it is involving the symmetrical polyarthritis and tenosynovitis. So it is involving multiple joints and also symmetrical. Both the sides of the body are being both the sides of the body. That is both the joints are getting affected. And tenosynovitis is seen. That is there will be inflammation of the tendon sheath. So this tendon sheath is nothing but it is attaching the muscle to the joints. So there will be inflammation of the tendon joints, tendon sheath, as well as synovial joints. And there is morning stiffness, elevation of the erythrocyte sedimentation rate, and also there will be appearance of autoantibodies that is targeting towards the immunoglobulins in the serum. So you know that the autoantibodies are nothing but the rheumatoid factor. This is the common autoantibody seen in the arthritis. So it is targeted toward the IgG immunoglobulins. So coming to the epidemiology, you can see that 1 to 3% of the population are being affected worldwide, and it is more prevalence is seen at the age of 30 to 50 years. And women are more commonly affected than men. So if you take the Indian population, you can see that 180 million people are being affected with arthritis. So it not only affects the joints, but also it is progressing to the, it starts to affect the, first it starts with the knee joints, then it is affecting the other joints, then tissues and other organs of the body also. So you have to take a proper step to prevent the progression of the rheumatoid arthritis. So you can see in the picture the healthy joint and the RA affected joint. So you can see in that healthy joint there is a good cartilage and also the synovial membrane is there, tendon sheath is there. Then there is synovial membrane surrounded by the joint capsule. So all are healthy. But if you take that arthritis affected joint, you can see here there is inflammation of the synovial membrane. Okay, there is inflammation of synovial membrane, and because of that there is reduction in the joint space, and this is leading to the wearing of cartilage, and also there is formation of bone erosion. So you can see in this picture, so there is inflammation of the synovial tissue, and this inflammation it is leading to the pannus formation. So pannus is nothing but a mass-like formation. So there is abnormal proliferation of the synovial tissues, and it is leading to the pannus formation. So this pannus formation, what happens is it is getting activated. Okay, so this it is getting activated, and it is leading to the destruction of the cartilage. So and it releases the matrix metalloproteinases. So these are the destructive enzymes. It releases matrix metalloproteinases. And also there is activation of the chondrocytes in the cartilage. You know that cartilage consists of extracellular matrix and also chondrocytes. So there is activation of the chondrocytes, and this is also releasing the matrix metalloproteinases. So this is a destructive enzyme, and thereby it starts to destruct the cartilage. And finally, there will be narrowing of the joint space. You can see that the joint space is narrowed, and it is leading to the destruction of the bone. So this is how the pathogenesis of rheumatoid arthritis occurs. So it is a systemic disease, most common characteristic lesions are seen in the synovium. First, it is affecting the synovial joints, and there is formation of rheumatoid nodules are there. And you know that synovium is fully supplied with the blood vessels. So because of this blood vessels, what happened? There is more inflammatory reactions are happening in the synovium, and it is packed full of inflammatory cells. So coming to the exact pathology, what happens in RA? So when any antigen is suspected, okay, when any antigen entering into the human body, what happens? It is recognized by the MHC class 2 proteins. So MHC is nothing but the major histocompatibility complex. So why we are calling it as complex means it's a cluster of genes seen in the chromosome 6. So every cell, it is expressed on the every cell receptors. So this MHC proteins are expressed on the every cell receptors. Mainly it is seen in the chromosome 6. So this class 2 proteins are nothing but the antigen presenting cells. So they'll be presenting the antigen to the CD4 T cells. So hence they are called as the antigen presenting cells. So this antigen presenting cells are found on the cell surface of mainly the macrophages, then B cells, thymus glands. So this MHC class 2 proteins are seen on the macrophages and the B cells. So it is presenting that antigen to the CD4 T cells. So once the CD4 T cells is getting activated, it starts to produce the cytokines and the tumor necrosis factor. So all these are nothing but the pro-inflammatory mediators. So this cytokine, it will cause the macrophage activation, and again it leads to production of more number of cytokines, and interleukin 1 is produced. So this is activating the cell-mediated immunity. So this activation of CD4 T cells will be leading to the cell-mediated immunity. So this will activate the fibroblast, chondrocytes, synovial cells, and thereby it will be causing the release of various destructive enzymes which will degrade the synovial tissue. And same way, the cytokine is also activating the B cells. You know that B cells are responsible for the humoral mediated immunity. So this B cells, and also it is responsible for the formation of the antibodies. So it is also causing the B cell activation and formation of rheumatoid factor happens. So autoantibodies are produced. Autoantibodies. So these antibodies are targeted toward our own bodies. Okay. So it is leading to the autoantibodies and immune complex formation and deposition. So this leads to the joint injury. And also it is also leading to the endothelial activation. So it is all there is endothelial activation means that the endothelial wall surface in the blood vessels, the endothelial surface is getting activated, and there is expression of more adhesion molecules. And when there is expression of more adhesion molecules, there will be accumulation of the inflammatory cells. So this is also producing that prostaglandins, and this prostaglandin is also leading to the pannus formation, and thereby causing the destruction of the synovial tissue and this cartilage. So this is how the pathology of the RA occurs. So you should know that MHC class 2 proteins, mainly this is responsible for the activation of the CD4 T cells. So that antigen can be either viruses or any genetic susceptibility. That is most commonly in rheumatoid arthritis, that is HLA-DR1 and 4 are more commonly expressed on the antigen presenting cells. So this genetic susceptibility or any other factors that is triggering the CD4 T cells will lead to arthritis condition. So it is leading to the production of pro-inflammatory mediators. Then it is activating the fibroblasts, chondrocytes, and synovial cells. So all these cells are getting activated, and it releases the various destructive enzymes like matrix metalloproteinases, which is causing the destruction of the synovial tissue as well as the cartilage. So coming to the clinical manifestation. So where does this rheumatoid arthritis attack? So you can see that it is commonly affecting the shoulder joints, hip joints, knee joints, ankle joints. So that too in tarsal. In ankle, you can see that metatarsophalangeal joint has been affected. In hands, you can see that distal interphalangeal joints, proximal interphalangeal joints, and metacarpophalangeal joints are being affected. And it's also affecting the elbow joint. So these are the most commonly affected joints. So first it starts to affect the joint, then it invades the various tissues, then it is invading various organs, and it is causing many complications. You can see in the next picture the complications. What are the complications of rheumatoid arthritis? You can see here. So in the eyes, you can see that it is causing scleritis. So it can cause dry eyes, dry mouth. That's Sjögren's syndrome. So Sjögren's syndrome is it is a form of an immune attack. So where there will be formation of dry eyes and dry mouth. Okay, and lymphadenopathy, that is enlargement of the lymph glands. Then pericarditis, it is affecting the heart. Then bursitis. So this bursa is nothing but the cushion-like thing. It will be supporting the joint. So this there will be inflammation of the bursa. Then tendon sheath swelling will be there. Tenosynovitis will be there. Amyloidosis will be there. That is formation of amyloid proteins, and these amyloid proteins getting accumulated in the various organs, and it's leading to various organ failure. Okay, and also it is causing anemia. Then you can see that carpal tunnel syndrome is produced. Carpal tunnel syndrome is nothing but there will be a formation of pinched nerve. Pinched nerve will be formed. That is, there will be dislocation of the radius as well as the ulnar region, and because of that, there will be pinched nerve, and there will be numbness and tingling sensation. So that is the carpal tunnel syndrome. Then there will be nail fold lesions. So you can see that because of vasculitis, there will be clot formation in the nail beds. Then splenomegaly. It is otherwise called as a Felty syndrome, enlargement of the spleen. So this is the Felty syndrome, leg ulcers, ankle edema. So all these are the complications of a RA. Untreated RA can lead to all these complications. So you don't think it is just a joint disease. It starts to affect the joints, invades other organs, and it's leading to multiple complications. And if you see the clinical manifestation, so you can divide into early features. What are the early symptoms? So first thing will be the synovitis. So most commonly affected joint, I said, is metacarpophalangeal joint and proximal interphalangeal joint, wrist, tendon sheath around the joint. So these are the more commonly affected joints, and also it is leading to the inflammation of the synovial membrane. So it is also causing the bilateral symmetrical polysynovitis, and it's also leading to pain, fusiform swelling, stiffness, loss of mobility. And you can see the constitutional symptom. There is loss of appetite, loss of weight, malaise, low-grade fever, tenosynovitis. All these are the constitutional symptoms seen in the early presentation of a RA. And if you can go for the late stages, so late stages are nothing but the destructive stage. So it is spreading to the other joint. It starts in one joint and symmetrical joints, and it is spreading to the other joint. So it is affecting wrist, ankle, knee, and shoulder. So you can see the order of frequency. First, it starts in the wrist, in the hands. Then it goes in, affects the ankles, then knees, then shoulder. So this is the order of frequency, how the joints are being affected. And most common feature of this RA is they'll be having an early morning stiffness. They cannot do any activity because of the joint rigidity. There will be rigidity and morning stiffness seen in the joints. And also it will be improved with activity. So you can see that when they are doing their activity, when they are starting their activity, this symptoms will be relieved. And it is also mainly affecting the quality of life of the patient. If you're not able to function properly, you cannot do your physical activities properly, what will happen? It will ultimately affect the quality of life. So what are the deformities caused? So deformities means disabilities caused in the body. So disabilities, so it is causing the joint deformities. Most of the joint deformities are formed. So I'll list out the few. Thumb deformity, it is called as the Z deformity. Then in fingers, it is causing the swan neck deformity, botiner deformity, and ulnar deviation. In wrist, it is forming the radial or volar displacement. In elbow, it is causing the limited extension. Limited extension means limited movement of the elbow. That is, the elbow joints are becoming more rigid and there is limited movement. In shoulder, it is causing the limited abduction. So abduction is nothing but it is moving away from the midline of the body. That is raising of the shoulders. So it is leading to limited abduction. Knees are swollen. Flexion of the valgus is seen. That is rising of the knees. The toe fingers are there. No, it will be somewhat raised. That is called as the flexion of the valgus. And toes are also clawed. So all these are the deformities seen in RA. So you can see in this picture how the botiner deformity is there, ulnar deviation is there, and swan neck deformity. So in swan neck, so mainly there is hyperextension of the proximal interphalangeal joints. So hyperextension means what? There is increased movement of the joint. So there is increased movement of the joint in the proximal interphalangeal joint and flexion of the distal interphalangeal joint. Flexion means raising. So you can see that in the fingers, the distal interphalangeal joints are somewhat raised, and there is extension of the proximal interphalangeal joints. If you take that Botiner deformity, it is opposite. The flexion, there will be flexion of the proximal interphalangeal joint and extension of the distal interphalangeal joint. And you see that Z deformity, that is Botiner deformity. So there is radial deviation of the wrist and ulnar deviation of the digits. Somewhat it is like different different appearance is seen. So it is the radial deviation. The wrist is radially deviated, and there is the digits are deviated towards the ulnar region. That is, the fingers are deviated towards the ulnar region, and radial bone is deviated toward the wrist. Towards that radial deviation is seen. Coming to the diagnosis, mostly it is done by the radiological findings. It is also done by the physical findings also. You can see that you can look for that deformities in the bone, whether it is a Botiner deformity or a swan neck deformity. These are through the physical findings. Apart from that, you can go for the radiological findings. So X-ray findings reports early stage. So early stage, you can see that there will be inflammation of the synovial membrane. Synovitis will be seen. Soft tissue swelling, periarticular osteopenia, that is loss of bone will be seen in that area. In destructive stage, there will be juxta, that is erosion, narrowing of the joint space. All these are seen. That is near. That is very. The bones are very near. That is joint space is reduced. The space between the joint, it is reduced, and it is leading to bone erosion. So this is seen in the destructive stage. And in advanced stage, it is leading to the deformities. Whatever deformity I said, that swan neck, Botiner, Z-shaped deformity. So all these deformities are seen in the advanced stage. Coming to the hematological investigation, if you go for the full blood count, you can see that there will be appearance of normocytic hypochromic anemia. So normal RBC cells will be there, and the color of the RBC cells will be reduced. That is hypochromic anemia. It is due to the abnormal erythropoiesis from chronic inflammation. You know that it's an inflammatory disease, so mainly affecting all these cells, RBC, and it is leading to abnormal erythropoiesis. And you can see that inflammatory markers like ESR, CRP are elevated, erythrocyte sedimentation rate, C-reactive protein. So all these are the inflammatory markers which is found to be elevated in the blood examination. Then there will be presence of rheumatoid factor. I said it is an anti-IgG or autoantibody. So it is seen in the 80% of patients. Not all the patients will present with the rheumatoid factor. Only 80% of patients will be presenting with the rheumatoid factor. Those 20 who are not having that rheumatoid factor also, some may be positive for maybe having RA. So you cannot say that it is this test is having the exact sensitivity. You cannot say that it is giving exact result. But if you say take that anticyclic citrulinated peptide, it is most commonly seen in RA patients. So this is the common test now they are doing, anticyclic citrulinated peptide antibodies. Then they'll be going for this synovial fluid analysis. They'll be doing the fluid aspiration, and they'll be checking for the certain analysis that will be done. So if you take that rheumatoid arthritis, it is an inflammatory type. It is an inflammatory type of arthritis. So there will be the appearance, this synovial fluid, no, it will be appearing yellow, cloudy, and also decreased. And the cell count will be 2,000 to 75,000 cells will be seen. So if you see that there is a cloudy appearance of the synovial fluid and yellowish coloration, and this polymorphonucleoside neutrophils are ranging from 2,000 to 75,000, you can confirm that the patient is having some sort of RA or SLE or gout. So next is anti-CCP, new specific test for RA. So already I said rheumatoid factor, it is only showing positive in only 80% of patients. So if you take this anti-CCP, it is important for pharmacists to be aware that while positive serology, RF or anti-CCP results, it may indicate a patient with more progressive or active disease. So whenever a patient is presenting with RF factor positive or anti-CCP factor antibody positive, then you should identify that he's in under a aggressive condition. He's in a active disease and more aggressive condition. So this anti-CCP antibody is a relatively new test that is having similar sensitivity but higher specificity for RA. So it is having almost same sensitivity only, but it is more specific than RA. And it is a stronger predictor of erosive disease. So what is the practice tip for pharmacists means you have to encourage the patient to undergo the anti-CCP blood test as ordered by the rheumatologist. Then coming to the complications, so it will be leading to fixed deformities, muscle weakness, infection, spinal cord compression, systemic vasculitis, amyloidosis. So I said amyloidosis is nothing but the formation of amyloid proteins and getting accumulated in various major organs like liver, kidneys. So it can also lead to renal failure. Organ failure can be happening because of amyloidosis condition. So all these are the complications of rheumatoid arthritis. So treatment for RA. What are the therapy goals? So the goal of RA treatment is remission, and when not possible, you have to try to go for a remission. That is, you have to try to go for a cure. But you know that RA is a autoimmune disease which cannot be cured. So you have to take various steps to minimize the disease activity and to control these symptoms. You have to halt the damage. So you know that joints are getting damaged. You have to stop the damage of the joints, prevent the disability formation, and also you have to try to improve the quality of life of the patient. So these are the therapy goals. You try to minimize the disease activity, halt the damage, prevent the disability, try to increase the quality of life of the patient. So this can be done by the various treatment drugs. So monitoring and therapeutic adjustments. So healthcare providers of RA should monitor the disease activity as frequently as every 1 to 3 months in patients with active RA. So when a patient is presenting with rheumatoid arthritis, you have to encourage the patient that he should come for a review or a follow-up within 1 to 3 months. So he is having an active RA. Active RA means what? It is progressing. It is trying to progress. So in that condition, it is better that patient should be coming for a proper review or a follow-up within 1 to 3 months. So if the patient is having a good control over RA means you can you can increase the intervals. You can increase the time of the intervals. You can ask him to come after 6 months. Okay, and frequent assessments and follow-up for adjustment in treatment in unstable are associated with the improved outcomes. So you have to do frequent assessments in case of unstable patient. You cannot predict the progression of RA. In that cases, you have to go for a frequent assessment. If he's having a stable RA and he's having a good control over the RA means you can increase the time interval. So practice tip, what are the practice tips for pharmacists? So they are well positioned to remind patients with RA about the importance of keeping follow-up appointments and required monitoring such as laboratory test or eye examination. So as a pharmacist, you have to advise the patient why he has to keep up the follow-up, because this RA will progress and it will lead to various deformities. So you have to advise the patient to keep the follow-up and also monitor he has to do all the laboratory tests. So you have to check for all the laboratory tests done. That is sometimes various drugs used for this RA. It can cause liver toxicity, hepatotoxicity can be causing hepatotoxicity or GI toxicity. So it is these laboratory tests are required for the patient to assess the progression of the disease and how far the drug is working for the patient. And also it is causing various eye problems, scleritis, dryness of the eyes are seen. It is also affecting the cornea. So better eye examinations can be done for this patient. As a pharmacist, you can advise for all these tests. And adjustment in therapy may include dosage changes or adding or switching the DMA RDS therapies. And you can use possibly short-term corticosteroid treatment. You can use that is majorly for managing the pain. They'll be going for the NSAIDs. Then the first line drug therapy will be the disease modifying anti-rheumatic drug. That is DMAT therapies will be used. And along with DMAT therapies, you can use steroids also. Corticosteroids can be used, but you have to go for a low dose corticosteroids. Next is approach to the treatment regimen. How we are going to, as a pharmacist, how we are going to manage the treatment regimen. So in case of onset of disease, so when there is in the early stage, the RA is in the early stage, in that condition, you start with the NSAIDs and advise the patient for the physiotherapy exercise can be advised to the patient. In case of early stage disease, that is from 6 to 12 months, during that period, you start with NSAIDs and he is not he's not responding properly, you add a low dose corticosteroid, and there should be one disease modifying anti-rheumatic drug. You advise for physiotherapy or splintage. Any assistive devices can be advised for the patient in early stage RA. And in case of progressive erosive RA, that is from 1 to 5 years, you have to add this is disease modified drug and splintage. Yeah, DMAT should be added, and also you can advise for the surgical. He has to go for the surgical management because he's in an uncontrolled condition. So he have to go for no other go. He has to go for a surgical management like synovectomy or arthroscopic surgery should be done. Later in 5 to 20 years, they can go for a reconstructive surgery. That is arthrodesis or osteotomy or arthroplasty. So these are the reconstructive surgery. reconstruction of the joints will be done. So these are the approaches to, these are the treatment regimen to be followed in the arthritis patient. So coming to NSAIDs, so the most commonly used NSAIDs is ibuprofen and indomethacin. So you know that NSAIDs, it will cause GI bleeding and GI ulceration. These are the problems because these are the problems associated with NSAIDs. You're going to take NSAIDs for a long time. It is a chronic disorder, a lifelong disorder. So he has to take NSAIDs. So for managing that pain. So they'll be giving ibuprofen, indomethacin and all. And COX-2 inhibitors, like celecoxib, valdecoxib, it will be helping in reducing the inflammation and relieving the pain also. So most commonly, it is causing the GI ulceration and GI bleeding. So in that cases, you can use COX-2 inhibitors, which is having a better safety GI profile. So you can go for a COX-2 inhibitors. Then analgesics, morphine and acetaminophen will be used for reducing the pain, and steroids, glucocorticoids, or prednisolone, that too in a very low doses, are given to reduce the inflammation. So what are the practice tips by the pharmacist? So inform the patient of the non-medication related risk of bleeding ulcer. You know that NSAIDs is causing ulcer and bleeding. So you have to inform the patient that this can increase the risk of bleeding ulcer. So these ulcers are usually painful. But most of the cases, if you take RA cases, means they'll be having asymptomatic GI bleeding. They'll be having asymptomatic. Asymptomatic means they'll not be having any symptoms at all. Okay, you have to inform the patient about what are the signs of GI bleeding. So these are the black tarry stools or sticky stools. All these are the symptoms of the GI bleeding. So as a pharmacist, you have to inform the patient that NSAIDs will cause, on long-term use, will cause GI ulcer, and you have to check for any GI bleeding. How you will check the signs of GI bleeding? You have to check for the black tarry or a sticky stools present. So this signs of GI bleeding should be investigated for cause and treatment. How are GI symptoms? While taking NSAID does not mean an ulcer is present. You have to keep clear that sometimes the patient may have this black tarry sticky tool, not only because of taking NSAIDs, but because of any other problems also, any other problems also, you can have this symptom. So you have to say that not every time this GI symptoms represent that he is having some ulcer. You should not threaten the patient also. So next is DMARD therapy. So it is the disease-modifying anti-rheumatic drugs. So they are used along with NSAIDs or low-dose steroid to slow down the joint destruction caused by RA over time. So examples of disease-modifying anti-rheumatic drugs are methotrexate, sorry, injectable gold, penicillamine, azathioprine, chloroquine, hydroxychloroquine, sulfasalazine, oral golds. So most commonly used DMARD is methotrexate. They use hydroxychloroquine, sulfasalazine, and leflunomide. So these are the most commonly used DMARDs. And you know that DMARDs, it is having various problems. It can cause various toxicity, like it can cause hepatotoxicity, GI toxicity, pulmonary toxicity. Many problems are there with the DMARDs use. So you have to properly select the DMARD use, and you have to monitor the DMARD drug therapy given to the RA patient. So what are the practice tips by the pharmacist? The pharmacist should alert the prescriber and suggest possible alternatives to trimethoprim. You know that most commonly used, the first line DMARD is methotrexate. So when you're using this methotrexate along with trimethoprim, it is causing various problem. It will cause various problem in the patient. So this combination should not be used. As a pharmacist, you should monitor that when he is on methotrexate therapy, they should not add any trimethoprim drug. And also you encourage regular blood work monitoring for the patients on methotrexate or leflunomide. Go for the liver function test. Go for the liver function test, and regular blood test should be done to monitor the any toxicity produced in the patient. And they should not take any natural health products or any OTC drugs when they are taking this DMARD therapy or the NSAIDs. And they should not use, already they are prescribed with NSAIDs, and they should not use self-prescription NSAIDs. That is, OTC drugs should not be taken by the patient. So that thing also can be advised by the pharmacist. Then there is a new class of drug which is called as the biological immunomodulators. They are the biological response modifiers or biological DMARDs. They are called as the biological DMARDs. So most commonly, it is very effective for RA treatment, but these treatments are very expensive. The patient cannot afford for these types of treatment. So many biological derived DMARDs have been approved for the treatment of RA. They are characterized as TNF inhibitors or anti-TNFs. So these class of drugs, that is adalimumab, etanercept, infliximab, all these are coming under the TNF inhibitors. So, in the mechanism, in the pathogenesis, there is T4 cell activation, which is leading to the production of TNF and interleukins. So this immunomodulators, it is going directly targeting the specific proteins, which is causing the destruction. So it is this TNF inhibitors, it is blocking that TNF action and thereby preventing the progression of RA. So this adalimumab, infliximab, etanercept, all these are coming under TNF inhibitors. And B cell depleters. So you know that B cell activation, it will be leading to the formation of autoantibodies. So this rituximab, this drug, it will be stopping the B cell action. And next is interleukin 1 inhibitors. There is anakinra and interleukin 6 inhibitors. So most that in the pro-inflammatory mediators, most commonly causing the destruction is interleukin 1 and interleukin 6. So this is targeting, this anakinra is specifically targeting that interleukin 1, and in this tocilizumab, it is targeting the interleukin 6, and it is inhibiting the action. So either they are administered by the subcutaneous injection or the intravenous infusion route only. So this administration should be taken under the supervision of a rheumatologist. So the patient should be getting admitted in the hospital, and he has to take all these injectable biological immunomodulators. If you take that DMARDs, this methotrexate, sulfasalazine, all can be taken in the oral route, which that is we can prescribe the drug to the patient, they can take in the home. But if you take this biological immunomodulators, all are given by the subcutaneous or the intravenous route. So certain drugs, subcutaneous injection can be given in shots. So you can, as a pharmacist, you can advise how the drug should be given in the subcutaneous route. And certain drugs, infliximab, this drug will be given in the intravenous infusion route. So these drugs and all should be taken only under the supervision of the rheumatologist. Next is surgical therapy. So these are the, I have discussed about the pharmacological management. Next we'll be seeing about the surgical therapies. What are the surgical alternatives available? So coming to osteotomy. So it is nothing but the cutting the bone. So this procedure is to increase stability by redistributing the weight on the joint. So they'll be cutting the bone and they'll be equalizing the weight on the joint. So that is the osteotomy procedure. Next is joint replacement surgery or the arthroplasty. So there'll be the surgical reconstruction or replacement of a joint. So they'll be replacing an artificially man-made component, that is man-made joint, and they'll be reconstructing the joint. So this procedure is recommended over people of age 50 years and above. So mostly in 50 years and 50 above age, these people, they'll be having a decreased quality of life and decreased physical functioning, and they cannot perform the physical activities properly. So in that condition, you can give, they'll be going for the joint replacement surgery. So this new joint, it will be lasting for 20 to 30 years. Next is arthrodesis or the fusion. So they will be fusing the two bones together. So the procedure involves the fusion of two bones together. So while it limits the movement, when you're fusing the bones, there will be limitation of movement, and it is also stabilizes the joint. So coming to the role of pharmacist in management of RA. So already in the previous slide, I have given the practice tip. What are the practice tips for the pharmacist in management of RA? Now we'll have a just recollection of all these points. So you try to obtain the information from the patient with the help of the patient medication history. Try to prevent or identify or resolve the medication related problems. You try to prevent them, you find what are the medication related problems. I said DMARDs are causing many toxicities. You try to prevent those problems, identify those problems, or resolve that problems. Once the problems happen, try to resolve it. And also the choice of DMARDs depends on the stage and severity of the disease. So DMARDs, you can start first line with methotrexate. Then you can go with as a monotherapy it can be started. Then you can give it as a combination therapy, methotrexate with leflunomide, methotrexate with sulfasalazine, or methotrexate with the hydroxychloroquine can be given. Combination therapy can be advised. And this gold salts, azathioprine, and all, it is less commonly used only. Azathioprine, gold salts, very less commonly used. So you have to see what stage the patient is, whether he is in an early stage or in a destructive stage or in an advanced stage or in the destructive stage, deformity stage. So you have to identify which stage he is, what is the severity of the disease, and you have to identify which will be the choice for which DMARD should be selected. So many NSAIDs have significant side effects like including GI bleeding, fluid retention and all. So for long-term use, the risk need to be weighed carefully against the benefit. So when you're using it for long term, think of the risk. What are the risks will be created by this drug? And you try to weigh it with the benefits. Okay. So then you use the drug. If the risks are more compared to the benefits, better stop the drug or give an alternative drug for the patient. Or you give some remedies. So in case of GI ulcer, you can go for a proton pump inhibitor, or you can go for a more safe profile drug that is like selective COX-2 inhibitors. So you have to see the risk and you have to weigh the benefits. You have to see that risks are very less compared to the benefits. Then steroids also, you know that it is having many side effects. It may develop cataract in eyes. It is also causing bone loss, and also sometimes it will cause glucose tolerance. It can cause diabetes also. So these are the many complications of using steroids. So you have to monitor all these side effects in the patient and try to use the lowest possible dose, and also for a very shortest period of time. Counseling. Coming to the counseling points, what you provide to the patient is, so you know that you have to explain about RA. So it is limiting the physical activity. It leads to the loss of joint motion, contraction, and loss of muscular strength will be there. So physiotherapy can be advised to the patient to relieve the pain, inflammation, and also help to preserve the joint structure and function. So it is better you advise for the physiotherapy and the exercise that will be relieving the pain and the inflammation. And also you can, these are the non-pharmacological treatments. Then you can go for the application of heat and cold, which can relieve the pain or stiffness. You have to go for the heat therapy or a cold therapy that will relieve the pain or the stiffness. Then ultrasound may reduce inflammation of the use of sound waves, may reduce the inflammation of the sheaths, tendon sheath, thereby it will be relieving the tenosynovitis. Then you can advise for passive active exercises to maintain the range of motion of the joint. So you can give some exercises that will increase the activity or the range of motion in the joints. Then give a splintage to keep a joint from moving. So during rest, it can reduce the joint pain. And also relaxation techniques can relieve muscular spasm associated with the joint stiffness. So consult with the podiatrist. I said that it will cause vasculitis problem. So you consult with the foot specialist. In the hands, in the nail beds, it can cause vasculitis problems, and also it is causing pedal edema also. So you have to consult with the podiatrist who help with the orthodontics. That is devices that ensure the correct positioning of the feet. That is, there will be changing in direction of the feet and hands and all. So you can advise for the orthodontics also. You can help with the orthodontics. So these are the devices that will be helping in the positioning of the feet. So all these counseling point can be, as a pharmacist, you can do it for the RA patient to improve the quality of life and also physical functioning of the RA patients. So these are my papers. These are my research works. You can see that I have did the effects of clinical pharmacist education on lifestyle modification of post-MI patients. And also I did the pharmacist-led intervention in type 2 diabetes mellitus. So how you can, these are coming under the non-communicable diseases, how long-term diseases, chronic, how you can manage chronic diseases. What is the role of the clinical pharmacist? So I have did many studies. Next, my research will go on arthritis, I think so. Thank you all.
Thank you, ma'am. It was a very informative session. I have a question for you, ma'am. So, which NSAID can be preferred to treat?
You can go for selective COX-2 inhibitors, ma'am. So it is having a better GI profile, and also if you're using non-selective COX-2 inhibitors, you can go for adding proton pump inhibitors also.
Okay. Thank you for the session, ma'am. It was a glorious and thought-provoking session, ma'am. Moving on to the vote of thanks.
Thank you, ma'am. Thank you for giving this opportunity.
Okay, ma'am. I would now request Dr. Praveen, HOD Pharmacy Practice, to give the vote of thanks.
Good afternoon, everyone. That was a wonderful day we had regarding autoimmune diseases and its management. And at the outset, I would like to thank our chairman, Sri T. Jayapal Reddy sir, for being a guiding source for conducting all these webinars. I'd like to thank the LOC chair, our principal, Dr. P. Rajashekhar, for his constant support. And most importantly, I would like to thank all three speakers, Mrs. Manasavina Vallapadasu, who spoke about the importance of autoimmune diseases and the various ways to manage autoimmune diseases. She's from CISILS, and Ms. Shaili Makula from North Carolina, United States, who talk about the type 1 diabetes mellitus, and Dr. S. Sarumati, Associate Professor from SRM College of Pharmacy, who spoke about the management of rheumatoid arthritis. I once again thank all the three speakers for their wonderful session. And also, I would like to thank the organizing committee members, Ms. Shivani Ravala, the convener, Dr. Anadeep Chaudhary, Assistant Professor, St. Peter's Institute of Pharmaceutical Sciences, and Dr. Dharani, Assistant Professor, St. Peter's Institute of Pharmaceutical Sciences, for making this webinar successful. Also, I would like to thank all the teaching and non-teaching staff of St. Peter's Institute of Pharmaceutical Sciences, and also Srikanth sir for his support technically throughout this webinar, throughout all the webinars. Thank you, everyone, and we are sure we will meet you again on another session soon on Wednesday. Thank you.
Thank you, sir. Thank you, everyone, for the wonderful session. We hope to meet you in another session.